will hand over the stage to Dr. Shivam.
Good evening, all. Today we are all here for the seventh edition of Innovations in Oncology, and I welcome all the members. And I invite for the first session, I would invite Chairperson Dr. Nafees Ahmed Siddiqui for chairing this session on the first topic, immunotherapy in lung cancer 2020, ever increasing spectrum. And speaker for the session is Dr. Sushant Mittal. Over to you, Dr. Sushant Mittal, sir.
Thank you. Good evening, all, and thank you, Dr. Sumant, for giving me this opportunity for presenting the data on immunotherapy in lung cancer. Next slide.
हेलो डॉक्टर सुशांत
डॉक्टर सुशांत आपकी आवाज जा रही है
डॉक्टर सुशांत आप अपना वीडियो ऑफ कर दीजिए
Yeah. So the current trends in is to treat lung cancer, targeted therapy, and immunotherapy. Chemotherapy is nothing but we give drugs, cytotoxic drugs, platinum-based drugs, which are the backbone of therapy for patients of lung cancer. It kills the cancer cells in cell cycles. Targeted therapies are agents which directly act on the particular genetic mutation which has happened in the lung cancer patients, such as EGFR mutation. So erlotinib, gefitinib, afatinib is given, or ALK positive, then crizotinib or ceritinib is given. Similarly, now the latest development is immune checkpoint inhibitors, in which we all know that the cancer cells escape the apoptosis, they do not undergo cell death, and hence we need something so that the programmed death ligands are activated and they are able to kill the cancer cells. So for that, we have something new in the market now. It has been almost 3 years, is immunotherapy. Next slide. So these are the guidelines in which whenever a new cancer cell is diagnosed of the lung, we have to have these molecular testing done: EGFR, ALK, ROS1, BRAF, PDL1, and after these testing, we decide is to be given. So if the patient has a targeted mutation such as EGFR, ALK, ROS, or BRAF, then they are given targeted agent. However, if these target agents are negative and the PDL1 is more than 50%, then patient can be taken up for immunotherapy along as a single agent, or if PDL1 is less than 50, then immunotherapy with chemotherapy can be taken up. Next slide.
Yes, Arvind.
So this is the immune mechanism. This is the tumor cells. We can see it releases tumor specific antigen. The dendritic cells identifies them, and then naive T cytotoxic T cells bind with them, leading to activation of cytotoxic T cells, and the tumor cells are killed. Next slide. So next slide. Yes. So this is the mechanism which is more elaborated now. When these tumor cells bind to the PD1, they inactivate the cytotoxic T cells, and hence the cancer cells or the cytotoxic T cells are not able to kill the cancer cells. In the next cartoon, as I'll show you, next slide. Previous slide, please. Previous slide. So something, if we use something over here which inhibits the tumor cells, inactivating the cytotoxic T cells, which is the immunotherapy agent, the inactivated cyto T cells becomes activated and they kill the tumor cells. So with this hypothesis, This is the various trials of immunotherapy has been done. Next slide. So this is the pivotal trial, Keynote 024, pembrolizumab versus chemotherapy in the first line therapy of patients with PDL more than 50%. Patient stage 4, NSCLC, ECOG performance status 0 to 1 with no targetable mutations and PDL1 more than 50%. Pembrolizumab 200 mg every 3 weeks or chemotherapy based on the histopathology. And it was given until the progressive of disease or unacceptable toxicity. The primary endpoint was PFS and the secondary endpoint was OS and overall response rate. Next slide. So this showed a remarkable improvement in such patients. The purple line is for pembro and the blue and the red line is for chemo. And we can see at the end of 1 year, that is 12 months, the graph is separated. 10.3 versus 6 months. At the end of 1.5 years, that is 18 months, the graph is still separated, 18 versus 8.4 months. So in stage 4 lung cancer, if we have a PFS benefit of more than 10 months compared to chemotherapy, it is remarkable. Similarly, in overall survival, we can see that the median overall survival has not been reached till yet, whereas for the chemotherapies, it is about 14.5 months. Next slide. So recent developments with immunotherapy in patient with advanced NSCLC. Next slide. So one of the thought was there, if we can combine both chemotherapy and immunotherapy and achieve a better response. Why this hypothesis is being generated is because cytotoxic agents enhance antigen presentation and immunogenic cell death. Chemotherapy disrupts the immune evasion mechanism in the tumor microenvironment. Dose, schedule, and drug dependent needs to be checked out. It is something similar to make the enemy come out of the hiding place, and as soon as it comes out, the immunotherapy takes care of it and kills it. Next slide. So this was the study Keynote 407 in which chemotherapy plus immunotherapeutic agent was given in untreated metastatic squamous cell cancers. Patients were obviously in stage 4, ECOG performance status 0 to 1, pembro plus carbo or nab-paclitaxel versus placebo with carbo or nab-paclitaxel, followed by maintenance of pembrolizumab, and crossover was allowed. Primary endpoint was PFS. Next slide. So in this, the pembro plus chemo, which is the blue line, is being shown in which the PFS is significant. 0.56 is the hazard ratio, and the median PFS is the tune of 6.4 versus 4.8 months. Response rate was 58.4, and the patients did well on this study. Next slide. So as per the PDL1, what is expected is if PDL1 is less than 1%, then the immunotherapy doesn't do as well as the chemotherapy. If TPS score is 1 to 49%, immunotherapy shows a better response. However, if it is more than 50%, then the response is significant and remarkable, which can be seen on this graph. The graph starts separating at the start of the therapy and it remains till the end. Next slide. Similarly, overall survival, it was 15.9 versus 11 months. So 4 months overall survival benefit was there, and the p-value was significant. Next slide. Similarly, overall survival as compared with the respect to PD-L1 expression, if it is less than 1, the compared to TPS more than 50, the responses are better in TPS more than 50. The median overall survival has still not been reached in the patient who have been given chemo plus immunotherapy. Next slide. This is another study, phase 3 IM Power 131, in which chemo plus atezolizumab in an untreated metastatic squamous cell patients were taken. The randomization was atezo plus paclicarbo, followed by atezo maintenance. Next was atezo 1200 3 weekly with paclicarbo for 4 to 6 cycles, followed by atezo and just the chemotherapy, and the crossover was not allowed. Next slide. So similarly, in this, chemo plus immunotherapy agents had shown a better overall survival, especially in the category in which PD-L1 was high, which is 23 months versus 14 months. So almost 9 months benefit was seen in such patients. Next slide. In the investigator assessed PFS benefit, it was significant was for immuno plus chemo versus chemo alone. As we can see, the end circle 10.1 versus 5.5 months. Next slide. The OS benefit, interim OS on the basis of PD-L1, higher the PD-L1, higher is the response rate, higher is the median overall survival, higher is the PFS. So to test the PD-L1 at the correct lab and to choose the correct drug, choose the correct patient so that they are able to tolerate the immunotherapy along with the chemotherapy is the best bet nowadays for the patients of lung cancer. Next. Keynote 189, first line Pembro plus CT versus CT in stage 4 non-squamous cell. So Pembro was given with platinum pemetrexed followed by pemetrexed, followed by Pembro plus pemetrexed maintenance versus placebo with pemetrexed. Next slide. So the overall survival, again, we can see the PFS and the OS is significant. We can see from the graph, it is better if we combine both the therapeutic agents. Next slide. So PDL1 higher, again, it reinforces that higher the PDL1, more is the response rate, more is the OS benefit. We can see from this. It doesn't mean that patients who have lesser PDL1, they will not respond well, but they will not respond as great as higher the PDL1. So it's a directly in direct relationship to the PDL1 status. Next slide. So this shows the same thing for the PFS also. Next slide. Now the important point is, if we are combining two different therapeutic agents, does the side effect increase? Because we are treating the metastatic patient, we don't want to harm patient further. So if we see that Pembro, in 189 it was Pembro plus chemo versus chemo. So we can see any of the side effects, 67 versus 65, anemia 16 versus 15, nausea 3.5 versus 2.5, fatigue was little higher, neutropenia was little higher, but I think all of us are well trained to handle the neutropenia. So it shows that overall, adding immunotherapy to the chemotherapy, the side effects are not increased. It is as good or as bad as we are giving chemotherapy alone. Next slide. So this was a study of stage first line atezo plus carbocisplatin and pemetrexed in stage 4 NSCLC. So induction chemo was atezo versus platinum, atezo plus platinum plus pemetrexed 4 to 6 cycles, followed by atezo and pemetrexed maintenance versus pem carbo and pem maintenance. Next slide. So again, it shows that the median PFS benefit, it starts separating from the first day itself, from the first month itself, and it remains separated till the end. And the outcomes are better for combination therapy, 18.1 versus 13.6 months. Next slide. So this was then decided to add atezo plus chemo versus bevacizumab in untreated non-squamous cell carcinoma patients. Next slide. So it showed that atezo plus bev plus chemotherapy had a median PFS benefit of 8.3 versus 6.8, and it remained till the end. Next slide. And in the subgroup analysis, all kind of patients were favored with the immunotherapy plus bev plus paclitaxel. And we can see the diamond is away from the unity, whether it is PDL1 low expression, high expression, or if the intent to treat population, all of them did better with the combination therapy. Next slide. So with this, because of these data, the first line chemotherapy or the first line agent considered in lung cancer patient is pembro plus carbo and pemetrexed category 1, pembro cis pemetrexed category 1, atezo plus carbo plus pacli plus bev is another category 1 recommendation because of this robust data through these various clinical trials. Next slide. This reinforces the same thing that for the squamous also we can give PEM carbo pacli, PEM carbo with albumin pacli, which is preferred agent, or PEM with cisplatin and paclitaxel also can be given. Next slide. With this, thank you so much. The house is open for discussion if there are any questions.
Thank you, Dr. Sushant Mittal, for such a nice elaboration for immunotherapy in lung cancer, the therapy. Going to the next session, I would like to call upon our next speaker, Dr. Kundan Chaufal sir, and he would be speaking on managing brain metastasis in mutant non-small cell lung cancer lung and its integration with targeted therapy.
Thank you, Dr. Shiva.
Dr. Kundan sir.
Yeah. Am I audible?
Yes, sir.
I will share my screen. I'm going to share my screen.
Yeah, please share, sir. I have given you the access.
Second.
क्या पूछ रहे हो
Yeah.
इससे
Can you see my screen now?
Yes, sir. It is visible, sir.
Thank you. So good evening, everyone. At the onset, I would like to thank Dr. Sumant and the whole team of Innovations of Oncology, as now it has become an annual event kind of a thing. This topic as such for non-small cell lung cancer, if we look at the whole chronology of how the things have evolved over the past 2 decades, the same topic, if I would have to talk maybe 2 decades back, it would be like a 2-minute talk. But now with so much of things happening, as my previous speaker was talking about, in chemotherapy, we have from chemotherapy, we have moved on to targeted therapy and now immunotherapies. So same has impacted in the management of loco-regional control in these subgroup of patients. And in fact, there is now a whole lot of a new term which is called as an oligometastasis or oligoprogressive disease kind of a thing. So what I am going to talk today is a very specific pertinent subgroup of patients in non-small cell lung cancer patients who are mutant and who have a brain metastasis. So how to deal with these group of patients. So my whole talk would be divided into 2 parts. First would be how we are going to sequence with these targeted therapies as such. And now considering that we have a very good CNS penetrant targeted agents. So how we are going to sequence our local treatment for brain metastasis with these agents. And then the second aspect of my talk would be, is there any limit to the number of lesions where we can limit our talk to a very local, precise radiation technique called as stereotactic radiosurgery. So the relevance of this whole topic stems from the rapid and very gratifying improvement in survival observed in this patient population. So this allows more time for brain metastasis to develop and for patients to face the consequences of radiotherapy. So while in the recent past, the appearance of brain metastasis prompted reflex whole brain radiotherapy, we move towards a stereotactic radiosurgery. So there is now irrefutable evidence that mutant non-small cell lung cancer have a higher rate of brain metastasis, and for a while we were comfortable with sequencing SRS followed by TKIs. But with the emergence of CNS penetrating TKIs, the optimal management is again in a state of evolution, and with the emergence of immunotherapy, I anticipate that it is going to get a lot more complex. But before we delve into this topic, let's take a glimpse at the spectrum of survival in this group of patients. And it is astounding to see that some patients can survive up to 4 years after being diagnosed with brain metastasis, when just 2 decades ago, we expected only half a year. Some might disagree, but the progress has been the result of concerted efforts of both medical and radiation oncologists. So the journey from whole brain radiotherapy to stereotactic radiosurgery is a lecture on its own, but keeping in mind the multidisciplinary members of this meeting, I will stick to the key highlights. While it's currently fashionable to criticize whole brain RT for its shortcomings, it has served us well in the past. So before the turn of the millennium, whole brain RT was all we had to offer, something to the patients and their family. With the development of SRS, early results suggested that it had an incredible local control rate with several advantages over whole brain radiotherapy, but had a higher intracranial failure rate, which is why investigators focused on adding whole brain RT to SRS. But this did not result in any overall survival benefit. And a meta-analysis by Dr. Sehgal, in which almost 60% of patients had a lung primary, cemented the place of SRS in the management of 1 to 3 brain metastasis. So with increasing utilization of SRS and declining whole brain radiotherapy trends, survival in large database analysis almost doubled, and the Quartz trial suggested a diminished role of whole brain RT, though this trial had its own flaws. I will not go into details of that. So an alternative whole brain radiotherapy technique was developed, which preserved neurocognition by sparing the hippocampus while simultaneously delivering a higher dose of radiation to the macroscopic lesions. You will notice that this timeline ends somewhere around 2017. This is an important landmark, and its significance you will discover in my next few slides. So with that background, we turn our attention to mutant non-small cell lung cancer. So I was overjoyed to see the sequentially delivering tyrosine kinase inhibitors in mutant non-small cell lung cancer after stereotactic radiosurgery was further improving outcomes for our patients across diverse populations and ages. We were seeing a near doubling of survival and were phasing out whole brain RT from our algorithms. We also understood that concurrent TKI with radiotherapy is not a good idea due to higher risk of radionecrosis, as we can see in many of these retrospective studies as well as in phase 2 trials. So all was going well till around 2017. Medical and radiation oncology colleagues were finally coming together, but a tsunami was coming. And the tsunami which I am talking about is a tsunami of data on next generation TKIs. The impressive extracranial activity was matched by data suggesting that they were effective in preventing intracranial progression in patients with asymptomatic brain metastasis. So while reviewing the literature on each of these trials, I thought of describing every trial in some detail, detailing individual relative risk and hazard ratio for each agent and trying to draw some meaningful conclusion for this audience to take home. And instead, questions came to my mind. Were these trials powered adequately to answer the question of sequencing, or were they byproducts of exploratory unplanned subgroup analysis? Is there a reason why only a minority of them report objective local control rates, and why details of delivered RT were unreported, though they were allowed in these trials? Finally, all these trials did not compare survival or progression-free survival head-to-head with stereotactic radiosurgery. So if these trials were not designed to answer the question of sequencing, I would consider their conclusion of postponing SRS till progression simply hypothesis generating, not practice changing. We can continue this debate till the results of some of these ongoing trials in Australia, Canada, and US are published. And perhaps next year, I might be talking about how I was misguided in my current opinion. But till that time comes, let's look at this meta-analysis, which was specifically designed to study the sequencing of SRS and TKS. There are many meta-analyses. This was published in Green Journal. I chose this one specifically because this meta-analysis included the next generation TKIs also. There were a few of the trials which actually gave the next generation TKI also. The population was predominantly EGFR mutant rather than ALK mutant, reflecting the real world distribution of these mutations. And sequential SRS and TKI improved progression-free survival by 5 months, though missing the significance mark by just 0.01. And the difference in overall survival was not significant. So looking at this high quality multi-institutional data, I am compelled to predict that similar to the trials of SRS and whole brain radiotherapy, where appearance of new metastases were prevented by whole brain RT, resulting in improved intracranial progression-free survival, adding TKIs to SRS will also improve intracranial progression-free survival in mutant non-small cell lung cancer. Essentially, TKI could replace whole brain RT in our algorithms. But the premise of this whole approach rests on the question, so what is the limit? How many numbers of metastases can be treated with SRS? This is what is the subject of my next part of my talk. So is there a limit to the number of metastases which can be treated with stereotactic radiosurgery? And if you ask this question to the head of Japanese Laxal Gamma Knife Society, Dr. Yamamoto, and review his research on this very question, there are no limits on the number of lesions which can be treated with SRS, though there is a limit on the volume, how much it can be treated, the cumulative volume of all the metastases, but not on the number of metastases. And this pivotal JLGK0901 study is revered in the radiation oncology community as the first of its kind, proving that patients with 2 to 4 brain metastases had equivalent survival to those with 5 to 10 brain metastases. This came a full year before Segal's meta-analysis, which made SRS the standard of care for 1 to 3 brain metastases in America and Europe. A full 5 years later, Hughes et al. Replicated the results of Dr. Yamamoto in an American multi-institutional analysis, suggesting that the survival of 2 to 4 and 5 to 15 metastases were equivalent. Pushing the envelope even further, Dr. Yamamoto in his next analysis proved that patients with 2 to 9 metastases enjoyed equivalent survival and compared to 10 to 63 metastases. So they are the numbers doesn't matter, though the volume does matter. So for brain metastases arising from non-small cell lung cancer, his group replicated the results of JLGK901 study in this subgroup as well. Interestingly, when substratified by the type of treatment these patients received after SRS, TKI or TKI followed by chemo on progression, there were no statistically significant difference in between these subgroups. So since these TKIs were first generation TKI, consider the possibilities of adding next generation TKIs to SRS, as I had shown you in my previous slides. So it is not implausible to assume that our current preference of radiotherapy technique based on numbers alone will evolve from hippocampal avoidance whole brain radiotherapy for more than 4 metastases. Till now, we are treating 1 to 3 metastases, but this will evolve beyond 4 metastases. to more than 10 metastases, there is now emerging endorsement for this approach from the American Radiation Society, which announced just 1 month back in their annual conference. And hopefully ongoing head-to-head trials comparing SRS with whole brain RT will answer this question in the near future. But before we all head back to our clinic on Monday and start irradiating up to 10 metastases with a radical intent, let's for a very brief moment also consider the limitation imposed by technology. Dr. Yamamoto's result arise from a long experience with working exclusively with Gamma Knife, a single purpose delivery platform designed exclusively for intracranial treatments. Advances in technology like CyberKnife and linear accelerator-based SRS platform have wider availability and applicability. And as our experience with these platforms increases, we will appreciate the inherent trade-offs associated with each of these techniques. So in the interest of time and to maintain the attention of our multidisciplinary audience, it would be suffice to say that SRS planning and delivery is not an easy endeavor. From my own experience with delivering SRS for a single patient, I can safely say that it requires at least a full working day to create a high quality deliverable plan. But eventually it is immensely gratifying to see hard work pay off. In the last 2 years, we have treated almost 127 brain metastases in 58 patients with up to a maximum of 4 lesions per patient. So we are in the midst of analyzing our results and probably we anticipate sharing them soon. So to conclude, we try to follow this algorithm, and specifically if we focus on mutation positive asymptomatic TKI naive brain metastasis, where extracranial disease burden is not alarming, and if number of metastases are less than or equal to 4, we try to convince our medical oncology colleague to go ahead with SRS followed by systemic management. But sometimes it's very difficult to convince our medical oncology colleague, but we try to convince them. And if patient needs whole brain RT, then we definitely try to defer it as long as possible. And if in any case we have to deliver whole brain RT because patient is symptomatic or there are some other issues, then probably we don't give a conventional whole brain RT. We try to give whole brain RT with hippocampal sparing. Well, things are not so simple as it seems to be here, and everybody would comprehend it fully as if somebody would see our witness our medical or their medical multidisciplinary tumor board. To add to this complexity, the financial status of patients also play a major role in decision making with regard to choice of TKIs and technique of radiation. So finally, this topic is ever evolving, and we will have to adapt to this rapidly changing landscape. But somehow it is so heartening to see that we are discussing the management of non-small cell lung cancer with brain mets so that we have a prolonged survival along with good quality of life. While 2 decades back, the same scenario was considered as a lost battle. Hopefully, there is still a lot to come, and future may unlock our limitations in treating and further improving outcome in these subset of patients. Thank you. Thank you very much.
Thank you, Dr. Kundan, for nice presentation on radiation in lung cancer in the era of immunotherapy. And very thankful to Dr. Suman for giving me this opportunity. For next session, final discussion, choosing the right TKI in lung cancer, I will invite moderator, Mr. Respected Dr. Dinesh Pendarkar, sir, and panelists are Dr. Rohit, Dr. Samir Khatri, Dr. A.P. Dubey, Dr. Preetam Jain, Dr. Bharat Chauhan, Dr. Prateek Tiwari, and Dr. Arjun. Welcome, Dr. Dinesh Pendarkar, sir.
Yeah, good evening, everybody.
Good evening, sir.
Ravi, can you see if everyone is connected?
Sir, we have Dr. Arjun with us, Dr. Rohit Malde, Dr. Bharat Chauhan, Dr. Prateek Tiwari. Dr. Preetam is joining in 2-3 minutes.
Okay, so can we go ahead?
Yes, sir,
Is
please.
Dr. Sushant still with us?
No, Dr. Sushant is, I guess, not there. He's there, I guess. He's there.
Sushant, can you also please stay back for this panel discussion? Sushant, can you unmute yourself? Okay. Pandarkar sir?
Okay, so
Sir, 20 minutes, please. Thank you.
stop me at 19 minutes.
Thank you.
Okay, so
Okay.
everybody, welcome everybody, and we are happy you are joining with us in innovations. It had been our endeavor to do something new, and this time a new methodology. So the first slide I want to show you is we want to discuss TKIs in lung. So my first question to everybody would be, so these are the markers we do today. The basic biological markers which are done are PD-L1 in lung cancer, and these are the markers. So I will just read them out. EGFR mutation, ALK translocation, ROS1, MET amplification, BRAF mutation, NTRK gene fusion, KRAS, and RATE. So I think these are the markers which are relevant from TKI point of view. And do you all agree, or would you like to add something more? That's my question number one to everybody. Bharat? Dr. Bharat? Dr. Tiwari? Anybody? Is everybody listening?
Good evening, sir. Yeah, I'm okay with that, sir. These biomarkers are sufficient for adenocarcinoma or non-squamous cell lung cancer.
Carcinoma. Okay. So my first question is, will we do these markers only in adenocarcinoma, or there is a trend amongst ourselves to do them in squamous cell also? That's my question number one. Anybody would like to answer? Please go ahead.
Sir, we can do these markers in adenosquamous histology also. And EGFR expression may be there in squamous also, but though it is a very low percentage.
Okay. So as of today, I believe our trend is we are doing these markers only when we have a proven case of adenocarcinoma, sometimes adenosquamous. Is that right?
Yes.
Yes. Okay. So my next question is, so this is the marker which you are seeing. What is your preference to prescribe marker by name that you will advise the patient do EGFR, ALK, ROS1, or will you advise a lung panel, or would you advise a full NGS? Yes, anybody please.
Sir, and NGS will be better.
No, please. My humble request to everybody, I do not want to ask what is better or what is bad. I'm just asking you, what are we really doing? I know
Sir,
there are doctors who advise only 3 panel. There are doctors who advise something called lung panel. There are doctors who advise NGS. So we want to come to a consensus. What is most commonly done? Everything is
sir, most commonly done is because we are practicing in community, and most of the patients are not affording. So we are doing EGFR, ALK, and ROS because it can be done by coupon and free of cost.
Okay, very nice.
Others are not. Others are actually they have to pay. So we will discuss with patient if they can do it, then they have to pay.
Perfect, very nice. Any other? Bharat, would you like to add something? Sumant, would you like to add something?
Hi, sir.
Yes.
This Dr. Arjun this side. Sir, most of time we have issue regarding the tissue. Most of time we don't have much of tissue.
Okay.
And so it is better go with the NGS testing if we have affordability of from patient side, or there is no any issue about the cost and other things. It is better to go with NGS because in one test we can get in all the reports of the other mutation analysis.
Very nice. Okay. Any other suggestion? So if if we have coupons, then we'll do whatever is available through coupon.
Yes.
If patient can afford, NGS would be the best option. That's right?
Yeah, it's
Yes.
Perfect. So now we have done this testing, and so now one thing is very clear. If the patient is biomarker positive, then we would be going ahead with targeted therapy. So now let's dissect one by one. So now let's talk of EGFR mutation. So let's believe that the patient is EGFR mutation positive. Naturally, the guideline, all of us know very well that patient is any marker positive, the treatment of, so we have a case of adenocarcinoma, one of these markers positive, the treatment of choice would be to start with the targeted drugs against this mutation. So if there is a EGFR mutation positive, this is the list of drugs which I have written, probably could be used. Anybody would like to add something here? Maybe I have not spelled out. Osimertinib, afatinib, erlotinib, gefitinib, decomitinib, spelling is wrong, erlotinib plus ravasizumab or erlotinib plus bevacizumab. Any other suggestion? So if EGFR mutation is positive, these are the options available.
Yes,
Anybody else? Bharat, yes, please go ahead.
Yeah, sir, I think the list looks complete. List looks really complete.
Okay, so now if the list is complete, my question is, if you get a patient in clinic, EGFR mutation positive adenocarcinoma, what would be your drug of choice? One drug only, please.
Sir, looking at the data, I will start with osimertinib.
You will start with osimertinib.
Yeah, yes, sir. One drug.
Anybody else agreeing, disagreeing, or everybody agrees?
So the drug of choice would be osimertinib, and it's just a detailed patient history should be taken. And if the patient does not have, severe congestive heart failure, if the patient does not have interstitial lung disease, the thing is, those would be, 2 or 3, sort of major concerns if osimertinib is to be used.
Perfect.
So a good history and osimertinib would be the default option by choice.
Default option by choice. Excellent. So my next question is, there are some patients who cannot afford osimertinib for some reason. Then what would be your next best choice? If you cannot afford osimertinib, say financially, which is one of the most common reasons all of us are facing. So then in that situation, what next drug of choice you would have?
Sir, erlotinib or geftinib. I would go with erlotinib because it has got a better data, and now the generics are available and the cost is not an issue. So I will go with erlotinib, sir.
Very nice. So anybody else? Suman, Pratik, Dr. Mittal?
Sir, afatinib also generics are now launched. So afatinib, better to go for afatinib in respect than erlotinib.
I think if we have mutation of DEL19 mutation, then it is better to go with afatinib as compared to erlotinib or gefitinib.
Okay. So now that means osimertinib is sure we are using. If for whatever reason we are not using osimertinib, then the treatment of choice, we have now 3 opinions: erlotinib versus gefitinib versus afatinib. And especially the suggestion is, if you have if there is a DEL19 mutation positivity, then afatinib and not erlotinib, gefitinib. So we can segregate between the two. Very nice. So my question is, do we are we likely to consider erlotinib plus ramucirumab or erlotinib plus bevacizumab in this situation when we are not in a position to use osimertinib for whatever some reason?
Sir, we need more evidence. I think still data is not mature and there's no overall survival benefit.
Okay, so if I have written it here, it is from the guidelines. So there is data, there is approval, everything is there. So we are not talking data. We are not discussing data. So these are approved as per guidelines. But yes, I agree with you. For whatever reason, we have no explanation that we are not used to use erlotinib, ramucirumab. So first line osimertinib is very clear. If osimertinib unavailable, unaffordable, erlotinib, gefitinib, because they are cost effective. And if DEL19 mutation in again a low cost generic available, afatinib would be the choice. Probably this is how we would deal with EGFR mutation. So my question is, second line EGFR mutation. So you have used something and it has failed. What would be your second line choice of EGFR in a patient with EGFR mutation? So you have used osimertinib and patient is showing progression. What would be your second line TKI?
Sir, it's a very difficult question to answer at this point of time. The
Okay.
data is available for afatinib followed by osimertinib, which is a geotag trial. But osimertinib followed by anything, I think this is a very difficult question. That is why, sir, sequencing of TKI is of paramount importance. One should judicially use these TKIs so that you can offer some therapies. I feel others can answer, but I feel at this point of time, it is a debatable and open question.
So my question, Bharat, is, so you are saying that if you have a new patient with adenocarcinoma, sequencing could be better. So what kind of a sequencing do you have in mind?
Sir, I generally start with afatinib as I mentioned with geotag data, and plus the advantage with afatinib is it is a irreversible inhibitor of mutations, and plus it also acts on uncommon mutation. Somebody just pointed about the del 90 and the other issues. So I generally start with afatinib, and the patient if progresses in future, then I offer osimertinib. That is my sequence at present scenario.
Very nice. So you
Others can guide.
So you would not like to use osimertinib first line?
No, sir. I will not. I will not.
Yeah, but because you have a reasoning of sequencing, so you are using reason not to use osimertinib first line.
Yeah.
So
Yes.
Anybody had any other suggestion on sequencing? Anybody, please? Prateek, Dr. Mittal, Suman.
Sir, my opinion is we should, if we have a best drug in hand and patient can afford, so we should start with the best drug. Guidelines also says that osimertinib can be used. We know that if lung progresses, then most of the patients deteriorated and their performance status deteriorated. So I think 80-90, around 70% loses that window. So I think we should start with osimertinib.
Okay, very nice.
Right.
Arjun, would you like to same opinion?
No, sir. I'm totally agree with osimertinib, sir. Upfront, if you have the osimertinib in the market for patient affordability, then we start with the osimertinib, sir.
Okay, very nice. So now we have discussed first line and second line. So my question is, if there is a progression on osimertinib, would you like to continue osimertinib by adding or deleting something else?
Sir, some people are doing these things if they have a progression only one side. So they are doing some ablation or something and they will continue with the osimertinib.
Okay.
But if they have a systemic progression, then we should go for chemotherapy. I don't think any other option is leaving.
So would you like to continue with osimertinib and add chemotherapy, or would you like to remove osimertinib and switch to chemotherapy?
No, I want to remove osimertinib and start chemotherapy.
Okay. Totally agree, sir.
So if there is a T790, if there is a mutation, if there is a EGFR mutation, and if there is a second mutation, would you continue osimertinib or would you change?
The thing is, if patient is on erlotinib and most of them are progressing, about 80% of them, they have T79M mutation. And in that scenario, osimertinib is actually doing good. But if someone is progressing on osimertinib, I don't think they have other options.
Okay.
Any TKI left.
So if I can just add, the thing is, after using osimertinib, the thing is, if there is some accessible tissue and if a biopsy can be done, we could check for secondary mutation. And there is some evidence, if there is a secondary mutation with C797S mutation in the EGFR on exon 19, a first-line TKI can be used in this small category of patient. This happens 9% of the times.
Okay.
If this mutation is not present, it is immunotherapy or chemotherapy, which we are looking into.
Okay, so my question, very nice from what Rohit suggested. So I have a patient adenocarcinoma, started on osimertinib, and patient is progressing. So as Rohit has suggested, it will be really nice if I could do a repeat biopsy and a repeat sequencing. I am not able to get a tissue. Would you consider, if financially feasible, to do a circulating tumor cell analysis or ctDNA to find out a new mutation? Would you like to do a sequencing from the blood to look for a new mutation? Hello?
Uh,
Yes, Bharat, I think.
yeah, sir. Yeah, we have done EGFR testing and sequencing on this liquid biopsy, sir, and the results are good. But looking at the second generation mutations and looking at specific mutation, and when you are stuck with osimertinib and the patient has progressed on that drug, and it's a crucial point in your decision making, I am still doubtful whether liquid biopsy can help. But yeah, doing something rather than doing nothing is better than doing something. So
Okay.
one more important point in at this point of time I just want to highlight is that there is also an picture of pseudo progression. Whenever we use these TKIs and immunotherapies, we have to be 100% sure that it is a true progression. Then only, because the driver mutations, they are really good, and the patient is really sensitive to these drugs. So we have to also look at the element of pseudo progression, and we have to define progression in true sense, and then we have to go for tissue biopsy if feasible. If tissue biopsy is not feasible, the role of liquid biopsy at this point and this juncture is doubtful for me. So
Okay.
I will rather start with chemotherapy or immunotherapy as per the previous testing.
Okay. Okay. Very nice. Thank you very much. So now let's move to the next TKI. So ALK is another most common second translocation we see. So if there is an ALK rearrangement positivity, these are the 4 drugs probably which are available or approved. So alectinib, brigatinib, ceritinib, crizotinib. Is this enough, or there are a few other drugs which I have not mentioned? Yes, Rohit?
Sir, I think in India, the thing is, this list looks complete. We do not have access to brigatinib, but the rest we do have access to.
Okay, so again, my same question is, so we have a all positive new patient. You have all the 3 drugs available. With what drug would you like to start? You have access to everything. So would you like to start with alectinib or ceritinib or crizotinib?
Sir, I'll start with alectinib.
Okay. Anybody else? Everybody agrees, or you have somebody has a different opinion?
I totally agree with alectinib, sir. I will start with alectinib also.
So if given a chance, everybody would prefer alectinib. Is that right?
Yes.
Yes. Okay. So now the question is, if patient progresses on alectinib, can we go second line to ceritinib or crizotinib?
No, sir.
No.
No. So we switch over to either immuno or immunochemo.
Second line.
Yes, sir.
Sir.
Chemotherapy.
Yes, sir. Totally agree.
Okay. So my question is what Bharat had proposed in EGFR mutation. Can we not do a sequencing here? Start with ceritinib, crizotinib, and patient progressing switch over to alectinib.
Sir, these ALK positive cancer, these ALK positive patients, usually they have high burden disease, and most of them have CNS mets. So crizotinib is actually not very good in CNS penetration. So alectinib in that case is better choice. Although second option is ceritinib, which can be tried here. Third option is crizotinib.
Okay. So somebody is asking a question that if there is a small progression on a TKI, be it ALK or EGFR, or like somebody may call it as an oligo progression, fine. So would you like to continue with the same management,
Listen, sir.
or would you like to change?
Sir, in oligoprogression, we can continue with the same drug and we can ablate that lesion. Although I have seen the patients, they will progress very fast later on. But this is an option if we continue with the TKI and we can ablate the lesion.
Very nice. Excellent. So this is all about ALK. Let's go to ROS. So if there is a ROS1 rearrangement, the drugs available to us are crizotinib, entrectinib, and ceritinib. So entrectinib, I don't think is available in India, but crizo and ceritinib both available. So what would be our treatment of choice? First line. Yes, anybody please. Rohit, Bharat, Arjun, Suman, Dr. Mittal.
Arjun, I think is not. Arjun, are you there?
Yes, sir, I'm there.
Arjun, I think you should take this question.
Yes. So what
Arjun.
was drug? ROS1.
Sir, till date, I used only crizotinib ROS1 rearrangement, but I don't know the data about the ceritinib in this.
Okay, very nice. So crizotinib is available, and we can definitely go ahead with crizotinib. Agreed. This is just to refresh that whatever we know about these drugs. BRAF V600. So my first question is, did any one of you have ever seen a patient with BRAF V600E mutation in lung cancer?
Sir, can I answer?
Yes, please. Welcome.
Yeah, sir, I have seen one patient.
Okay.
At that time these drugs were not available in India. Almost 1.5 years back. So we imported these drugs because the patient was a doctor and they were having some relatives in US. So we have given this combination, and sir, within 3 months, patient progressed, and it was a definite BRAF V600E mutation. So I have seen one patient, and it was a very bad experience. So I don't know about others, but I have till now it is for me it is 100% no response rate.
Okay, Bharat, sir, may I also speak? Today,
Yes,
one patient has come with this mutation on NGS, so I really don't know now. With your experience, I am scared. Anyone has any experience with this now? What is to be done? I don't know.
See, today we have dabrafenib, teramitinib, I think, available in India. So I think we should go ahead with this combination. And there is no discussion because internationally, this combination has been in use as a drug called Mekinist, and people are very, very happy in any indication they are using. Most commonly, naturally used in melanoma, but
sir.
People are happy.
Sir, I have called him for Wednesday OPD for you.
Sir, Dr. Kundan has asked something.
Yes, please.
Patient on TKI with oligoprogression, how
He has
to
already
approach?
answered. We have answered that.
Okay, sir. Okay.
Sir,
We will take Kundan's help. That is what people feel.
Can I come in?
Yes, sir. Kundan sir, please join in.
Welcome. Yeah.
Sir, actually, we had a very, not a very large, but obviously the major chunk of patients which we are treating with this approach. Actually, we have not many patients who are on TKIs. They are doing well for 1.5 years, and then there is a one particular lesion which is progressing. Rest all is at place, static. We ablate that, and probably we get 6 to 8 months extra in most of the cases. Approximately 6 to 8 months with the same TKI they can continue. So this is one approach actually one should always consider if there is an oligoprogression.
So I would like to add a philosophy here. The international philosophy today is the radiotherapists have started to dominate the oncology field, and every oligometastasis today is indicated for radiotherapy, with which I totally agree. Same is for prostate, same is for lung, same is literally we are talking in breast cancer today. So probably we are really getting more and more data on radiotherapy, and probably we are more and more happy to radiate oligometastatic disease.
Thank you.
Do you agree?
Kundan sir.
I'm not promoting radiation. I'm saying
I'm not promoting radiation, but this is what the science is coming to, that we should use radiation in oligometastatic disease. Prostate, it is already indicated. Lung, you are already saying you are happy with it. Breast, already there had been a very recent data on a oligometastatic using radiation. So I think local radiation and which is a good modality. So now NTRK gene fusion, again now two drugs have become available, larotrectinib and entrectinib. So probably we should start looking for NTRK gene fusion positivity also. That's my feeling. And so I think these are all what we have the markers where we already have a TK available. And the recent data and addition had been RET positivity. Unfortunately, we are not doing it, but probably now there are two drugs available for RET positivity, RET mutation positivity also. I think we should start looking for RET mutations also, RET.
Sure.
So my question now is one, how many, if we do it, so how many patients you feel from general literature are ROS1 mutation positive? How many percentage? Vague, please. Vague answer is also okay, but please go ahead. Anybody? Bharat, how many percentage of lung cancer patients are ROS1 positive, for example?
Sir, 2 to 5%.
2 to 5%. And other mutations like ROS is the least common, I would say.
Mm.
And ALK positivity generally?
So again, I would club them ALK and ROS1 in one group, sir. Maybe 2 to 8%.
2 to 5%. Excellent. Very nice. NTRK probably would be even low. And RET would be even low. So maybe 2%, 1 to 2%. So now my next question is, if I do NGS testing in squamous cell carcinoma, what is the chance of getting some mutation positivity, any one of these?
Sir, squamous cell carcinoma?
Yes. So I do a testing NGS in squamous cell carcinoma. And out of all these genes, what do you think I may get a positivity?
Sir, actually, I generally ask for EGFR testing in many of my patients. And in fact, I have got quite a significant number of patients who are EGFR positive and squamous cell carcinoma, and they are on TK and doing well.
General
EGFR, yes.
So I'm asking
EGFR, yes.
percentile.
5%.
5% is the general data, sir.
Okay.
Yeah, 5%.
So now my last philosophical question to all of you, that you are doing ROS1 mutation when you are expecting a 2% positivity. You are doing an ALK mutation when you are expecting a 2% positivity, and you are not doing any NGS testing in squamous cell carcinoma where you are expecting a 5% positivity. So please let us all of us start rethinking as to why are we not doing testing in squamous cell carcinoma. If we are happy with 2% of ALK and ROS1 in non-squamous, non-small cell lung cancer, then why are we not happy with expected 5% positivity in squamous cell carcinoma? I think that's my last comment. But now I would request anybody for anything you would like to add on TKI, any message, all of you or one of you, please message for the audience.
Sir, I feel we should, as you have mentioned earlier, although osimertinib is a best drug, best data available, but I still feel that the role of sequencing is a key. And if you are stuck with osimertinib, then you have to offer chemotherapy in these patients. Rather than doing that, one should look at sequencing as a main goal and main theme in these kind of patients. That is my take, sir.
Okay, Rohit, would you like to say
So
something?
there was one more mutation which I wanted to mention.
Please
Is one of our patients has got MET14 exon deletion.
Okay.
And there is a drug available called capmatinib.
Yes, absolutely.
Which is a drug from Novartis.
Yes.
And it's available in India on compassionate use basis.
I think from these specific mutations are EGFR, L-cross, I think all of us will have to very frequently move to NGS now in lung.
Yeah, that is what my plea is. So I agree that the new mutation told by Rohit is absolutely right. I was just going to the list where I have that list. Yeah, so
There it is, MET.
yeah,
The
I have written MET.
amplification.
Amplification is definitely there. So
It's
now
there,
new,
sir.
new coming in is KRAS mutation. So there is now a drug available for specific one KRAS mutation. I think it's G12, G17, something like that. So for that also a new drug has become available with an excellent data in GI cancer. So soon we'll have to do KRAS also everywhere in lung as well.
So I
Yeah.
think NGS will be the answer.
I think NGS as a blanket investigation would be the answer, irrespective of primary histology. Yes, anybody else? Arjun, would you like to add something?
Nothing, sir. Nothing. This is sufficient.
Nothing. Anybody else? Kundan,
Yes, sir.
you
So
would you like to?
I think the choice of TKIs will also depend on the presenting metastatic site. Actually, if patient is presenting with brain metastasis, probably then you are compelled to start with an OSI rather than starting with a Jeffy.
Okay.
So
Okay.
that is something which we also have to keep in mind.
Excellent. So I would like to close, but before closing, I would just like to say, would Prashant like to add something?
Ravindra, can you unmute Prashant, sir?
He is already unmute. Dr. Prashant, we are not able to hear you. Please connect to your speakers or microphone. No, sir.
Okay. I think he's not able to join. Okay.
Sir, I think we'll wind up the session, sir. We are 10 minutes
Okay.
over.
So thank you very much.
Prashant, yeah, Prashant is back, sir. Prashant is there. Prashant?
Prashant, would you like to add something on TKI?
प्रशांत आवाज नहीं आ रही.
No, here's the problem, sir. Chalo, I think I would like to thank everybody, and let's hope that our next sessions go extremely well. Thank you very much.
Shivam, please take over for the next session.
That was a nice panel discussion, and I thank all the panelists, all the speakers. I also thank our chairperson, Dr. Nafis Ahmed. Coming on to the next session, due to some reasons, Dr. Tejinder, who would be chairing the next session, is not available. Now we move forward for the next session. The speaker for the session would be Dr. Wasim Abbas. He would be speaking on immunotherapy in non-small cell lung cancer, long-term survival outcomes with nivolumab. Dr. Wasim Abbas. Over to you, sir.
Dr. Wasim, we are not able to hear you. Can you please check your microphone connection? No, not yet. No, sir, still you are not audible.
Ravi, slides are also not visible.
Slides are coming, sir. Yeah. Sir, you'll have to check your microphone settings. There's an arrow button on the mic symbol.
Wasim, can you join through the mobile if possible? Ravi, unmute everyone, please. I think there's some problem.
So he's already unmuted, but this is a problem.
Bharat is also not able to unmute himself. Ravinder?
Yes, sir. I'm just checking. So I have given them access already to mute and mute. So next speaker, Dr. Jyoti is there. So can we go ahead with Dr. Jyoti Vadva? Meanwhile, I speak to Dr. Abbas and get the issue resolved.
Please, Dr. Ma'am को join करा लो.
Hello, Dr. Jyoti Vadva, ma'am. Yeah.
Yeah, hi, good evening.
Hello, ma'am.
Due to
Welcome, ma'am.
technical problems, we will be moving for the next session. Dr. Jyoti Vadva, ma'am, would be speaking on picking the right strategy for HER positive, HER negative, PI3 mutations in breast cancer.
So are my slides visible now?
Yes, ma'am.
And am I audible clearly?
Yes, ma'am.
Okay, so let's start. So the topic given to me for the talk today is picking the right strategy for patients with hormone receptor positive, HER2 new negative breast cancer patients who are also mutated for PIK3CA. So this talk is happening because we now have a specific molecule available to us in form of alpelisib, and this is a specific class 1 phosphatidylinositol 3 kinase inhibitor, in brief called PIK3CA inhibitor, and this has got approval for treatment of postmenopausal women and men who have hormone receptor positive, HER2 negative, advanced breast cancer, which is also positive for PIK3CA mutation. This is approved for use not in isolation, but in combination with fulvestrant after the disease has progressed following the prior endocrine-based therapy, which is usually an AI. So we know that almost 40% of patients with metastatic breast cancer who are hormone receptor positive and HER negative, in fact, harbor the PIK3CA mutation. And these patients, we have learned based on the research studies, they do worse, and their outcome is worse compared to those who are not mutated for PIK3CA. Now, how do we know? This is mainly based on the genomic analysis of 649 patients with metastatic breast cancer. These were the patients who had ER positive disease and had relapsed or progressed during endocrine therapy or within 12 months of completion of the adjuvant endocrine therapy, implying thereby that they were endocrine resistant. We also have a meta-analysis of almost 2,000 patients, and these two analyses revealed that presence of PIK3CA mutation was in fact a negative prognostic factor. It was associated with poor response to treatment and also overall worse outcome for these subset of patients. So in fact, PIK3CA mutation has now emerged as an important biomarker which could predict response to treatment and also predict the prognosis of these patients. Now, PIK3CA mutation indicates that there is higher cell proliferation and tumorigenesis. It is associated with endocrine therapy resistance and thereby poor prognosis and disease progression. So that's why it's very important to know the PIK3CA mutation status of the tumor in breast cancer patients who are hormone receptor positive and HER negative. Now, the drug alpelisib specifically addresses these mutations. In fact, these mutations, presence of these mutations lead to hyperactivation of the alpha isoform of the PIK3CA, and this is in fact a key upstream component of the PIK pathway. The drug alpelisib inhibits the alpha isoform 50 times more potently than the other isoforms, namely the beta, gamma, and delta. So the combination of alpelisib and fulvestrant, they in fact work synergistically to inhibit both PIK3CA and the estrogen receptor pathways. So this, we take advantage of this synergistic activity targeting two pathways by using this combination to treat this group of patients, and thereby we are able to overcome the resistance to endocrine therapy. Now, the study which led to approval of alpelisib in breast cancer was the SOLAR-1 study. This was the first phase 3 trial. It was a randomized, double-blind, placebo-controlled, multi-center phase 3 trial. In this, there were 341 patients who were harboring PIK3CA mutation. To be included in this study, besides being positive for this mutation, they had to be postmenopausal women or men more than 18 years of age, had to have hormone receptor positive and HER negative advanced breast cancer. They had to have either recurrent or progressive disease during or after AI therapy, and they had to have good performance status. So these patients, 341 patients, were randomized 1:1 into either receiving alpelisib in the dose of 300 milligrams once daily along with the standard dose of fulvestrant, or into a combination of placebo with standard dose of fulvestrant. PFS was the primary endpoint for this trial, and the secondary endpoints included the overall survival, the overall response rate, the clinical benefit rate, safety, and the quality of life. So what did this trial SOLAR-1 show? It showed that the combination of alpelisib and fulvestrant nearly doubled the median progression-free survival. So in the group of patients who received both alpelisib and fulvestrant, the median PFS was 11 months compared to 5.7 months in the placebo with fulvestrant group. And this is the study, this is the result that led to its approval and its position as category 1 recommendation in the NCCN guidelines also. Now, if we analyze the PFS results across the different subgroups, we find here that in fact all these subgroups seem to benefit. Patients, irrespective of the site of disease, whether it was lung, liver, or bone-only mets, whether they had been exposed to prior CDK4/6 inhibitors, whether they had received prior adjuvant or neoadjuvant chemotherapy, and irrespective of whether it was first line or second line use of this treatment. It also worked in both patients with primary and secondary endocrine resistance. Also, in terms of the secondary endpoints, it was noticed that the response rates doubled with the use of combination of alpelisib with fulvestrant. So the overall response rate in patients with PIK3CA mutation who had measurable disease was almost 36% compared to only 16% in the placebo with fulvestrant arm. And the overall response rate in all patients harboring PIK3CA mutation was 26% versus only 13% in the placebo with fulvestrant arm. So there was impressive doubling of the response rate as well. The tumor shrinkage was observed in 3 out of 4 patients who received this combination, and the responses were also deeper with this combination. So the drug has been approved. It's available in tablet form. Tablets of 150 milligrams, 150 milligrams are available. The dosing includes the standard doses 300 milligrams to be taken orally once daily along with food. And the fulvestrant dose is the standard that we use, 500 milligrams intramuscularly on day 1, 15, and 29, and subsequently once a month after that. And for facilitation of the dose reductions, a 50 milligram tablet is also available. Now, in the SOLAR-1 study, various side effects were noticed, and I've marked in red the significant ones. The significant in terms of not only frequency but also severity. So diarrhea was observed in the combination arm of fulvestrant and alpelisib in almost 7% of patients. Fatigue was a common side effect, but obviously both of these were manageable. Hyperglycemia is a peculiar side effect noticed in almost 37% of the patients. And another important and notable side effect is the rash seen in almost 20% of these patients. Now, the serious adverse events associated with alpelisib use do include severe hypersensitivity and sometimes anaphylactic reactions. So one needs to be careful. The cutaneous reactions, the rash can be severe. The hyperglycemia can also get out of control, and so can pneumonitis. The adverse events in the SOLAR-1 trial could be managed with additional therapy in almost all the patients, 97% of patients. Dose interruptions were required in 72% of patients, and almost half the patients required some dose reduction. Now, also in this group of patients, 25% of the patients had to discontinue treatment due to the adverse reactions compared to just 5% in those who received placebo with fulvestrant. And the most common reasons for the discontinuation of alpelisib were hyperglycemia, followed by rash and diarrhea and fatigue. So it's very important to remember these side effects of this drug. Now, let me talk about a little bit about hyperglycemia. This is in fact an expected and class effect of this group of molecules. So on the left hand side of yours, if you see, this shows the normal system in absence of alpelisib-like drug, PIK3CA inhibitor drug. So this is normal, wherein the insulin signaling is happening through the PIK3 pathway, and it's driving the glucose uptake into the cell, thereby controlling the circulating blood glucose levels. So when we use a drug, PIK3CA inhibitor like alpelisib, what happens? This uptake of the glucose from blood into the cell is blocked, leading to higher levels of circulating blood glucose. Now, this hyperglycemia is graded into 4 grades, 1, 2, 3, 4, depending on the fasting blood glucose levels, as is indicated here. And there are standard recommendations as to how to manage these different levels of hyperglycemia. So, if it's grade 1, no alpelisib dose adjustment is required. However, one may use metformin if the levels are 140 to 160 milligrams per deciliter. For grade 2 hyperglycemia also, usually no alpelisib dose adjustment is indicated, and usually this grade 2 also resolves soon. However, subsequently, after the resumption to normal levels, one may need to reduce the dose by 1 dose level. Now, it's important that these group of patients are treated with metformin, and sometimes we may need to add an insulin sensitizer as well to control the hyperglycemia. For grade 3 and 4, we need to omit alpelisib for some time and then restart after control of alpelisib, and usually we need to start with a reduced dose level. And if some patients' fasting plasma glucose is confirmed at grade 4 persistently, one may need to permanently discontinue alpelisib. Now, it's also very important to not just be focused around the drug and anti-diabetic drugs. It's also very important to manage these patients with lifestyle changes as well. So don't forget, as we do for our diabetic patients, do give them this advice as well. Now, how do we monitor these patients? So there are set guidelines. Once we start somebody on a drug like alpelisib, we need to check the blood sugar levels once a week for initial 2 weeks and subsequently once every 4 weeks. And HbA1c is another important parameter to be followed, and it has to be done every 3 months or as indicated clinically. The other second notorious side effect is the skin rash, as I mentioned in that table. And this was very important. As I mentioned, almost 1 in 5 patients in SOLAR-1 had skin rash. But if we use prophylactic measures, including antihistamines from the beginning at the initiation of alpelisib and during therapy, then one can significantly bring down the incidence of skin rash. As you see here, if the patients were receiving prophylactic treatment prior to the onset of rash, almost 73% experienced no rash. In the remaining 27% who experienced rash on prophylactic treatment, it was just grade 1 or 2 in 15% and grade 3 or 4 in only 12% of patients. So it's very important to be aware of this and very important to be using antihistamines for prophylaxis of skin rash from the beginning itself. So I think I have made it clear as to why we need to test. We need to test because we are here trying to identify that subset of 40% of patients who could benefit from this specific molecule. When to test? Ideally, it's recommended that we test it in the beginning when we are treating these patients of metastatic breast cancer who are hormone receptor positive and HER negative. The mutation status does not change, it remains stable. What's the methodology? There are two approved methods, either PCR based kit or the next generation sequencing. Which sample to use? It's usually recommended to do a liquid biopsy first, and if that's negative, then resort to tissue biopsy, as has been shown here also. And this is what NCCN guidelines also mention. To summarize, PIK3CA mutations are present in almost 40% of patients with hormone receptor positive, HER negative metastatic breast cancer patients, and this group does worse than the others. Alpelisib is a tablet formulation available to specifically target PIK3CA mutations. In the SOLAR-1 study, there was nearly doubling of the median PFS and also doubling of the response rates, and the adverse events were manageable and reversible. This is how we see it placed in the NCCN most recent guidelines. The second row, if you see it here, PCR-based test or molecular panel, and the combination is approved as category 1 recommendation and it's preferred second-line therapy. So I'll end my talk here. Thank you.
Thank you, ma'am, for a nice and illustrative description. Now I would like to invite Dr. Wasim Abbas, who would be speaking upon immunotherapy in lung cancer, long-term survival outcomes with nivolumab.
Yeah, thank you. Am I audible?
Yes, sir, you are audible now.
Yeah, thank you. So I thank everybody. I thank Sir and Dr. Suman. Thank you for giving me this chance to present in this meeting, to present the data, actually, immunotherapy in second-line non-small cell lung cancer. And we'll also review the long-term survival outcomes with nivolumab. And please, next slide. And so we know the problem that we have there's a rise in mortality and incidence of lung cancer. And if we see, we keep looking every day how these patients of lung cancer do progress. A lot of patients are diagnosed as a stage 4, and with time, as we see that these are the patients, even if we have a stage 1, stage 2, half of them do progress to stage 4 then. So we have a lot of burden of these stage 4 lung cancers. And if we go by data, Indian data, and we saw that there's a very less incidence, there's a less prevalence of driver mutation. And when we see, we have a data like our own institution, we saw that there's a 25 to 30% positivity, and especially that in adenocarcinomas. And smokers are usually negative, and squamous, as we have discussed, we have discussion before that, 5% are positivity for these driver mutations. And what we saw that when patient progresses, we have very few treatment options are available for such patients. Next slide, please. And what are the challenges? What are the challenges we face when we treat these patients as a second-line treatment? First, we have a lot of pretreated patients, and their performance status is not that great. We have low response rates. We have, these are symptomatic patients, their performance status is very low, and it becomes very difficult for a medical oncologist, for a physician to improve the symptoms or to improve the quality of life also from that stage. And so we always had an unmet need, and we also have an unmet need for better therapeutic options for second line treatment of non-small cell driver mutation negative lung cancer. Next slide, please. And if we go back a decade ago, and what we saw that different studies showed us definitely that a lot of patients don't receive second line therapy, didn't receive actually second line therapy. And there were so many reasons for that. First were that very less drugs were available, supportive care was not that great, and multiple reasons for that, and better drugs were not available, and there was no drug available after the first line platinum doublet. Next, please. And so I will be dividing my talk in 3 periods. One will be before immunotherapy, one my part of this will be, other period will be during immunotherapy, and third will be after immunotherapy. Next slide. Next. And if we go by this very busy slide, and we have a lot of trials, everybody knows we have Taylor, Titan, Beta, Vital trial, we have a bevacizumab trial, aflibercept trial, we have a venflurine trial, and even topotecan trials. And these trials definitely were all negative trials, and they didn't improve survival when we used them as a second line. And the only, even BR21, that was a erlotinib data that has a hazard ratios of 0.7 that showed a survival benefit. When we looked at that, and there were a lot of adenocarcinomas, it was thought that they must have been harboring the mutation, EGFR mutation, that was the reason of a survival benefit. The only winner which we saw was a TAX317 trial. And what it raised the bar, it was a docetaxel versus best supportive care. And definitely what we saw, that docetaxel was clearly a winner. And it definitely raised a bar, and it set a bar of 7.5 to 8 months of OS in a second line treatment. So we were expecting the next trials which will come, and they will definitely use a comparative arm docetaxel, and which they did all the trials, compared their drugs with docetaxel. Next. And there were other anti-angiogenic drugs. There are other anti-angiogenic drugs, and one is ramucirumab and other is nindatinib. And what did these 2 drugs show? Definitely it was a REVEL trial and a LUM-1 trial. And these were the 2 trials which again raised the bar, and which raised the bar from 7.8 months to 10 months. And definitely we have some now drugs apart from immunotherapy, definitely, which give us this OS benefit of 10 months. From 8 months, we moved to the 10 months OS benefit. Next slide. And updated analysis definitely showed that dosi plus ramucirumab and dosi plus nindatinib gives us the survival of 10 months to 10.5 months. And other drugs, dosi, PEM, and erlotinib, gave us the survival of around 7 to 8 months. Next. And there is also a debate going on. What happens to patients who progress very fast, who don't respond to platinum doublet, who do progress? What about them? And we know these are the very high risk patients. These are bad biology disease, what we say. And these are the patients who don't respond to any therapy at all, including immunotherapy sometimes as well. And what the LUM-1 shows, nindatinib and docetaxel data definitely did show that these are the candidates where we can use nindatinib and docetaxel, and this will give us a survival benefit of up to 10 months. And what happens to patients where best response is progressive disease to the first line therapy, to the platinum doublet? What is the survival there? And there also survival in LUM-1 was very impressive, which gave us a survival benefit of 9.8 months versus 6.3 months with placebo plus docetaxel. So this is a question of debate, definitely. Next slide, please. And now we come to immunotherapy, and I think everybody know. Next slide. We have 4 randomized trials, so there is a lot of debate. What should be the primary endpoint of immunotherapy, and that should be definitely the OS. So we have 4 trials that have changed really a game changer in the second line therapy of lung cancer. We know there was a first data started coming for nivolumab. It was Checkmate 017 and Checkmate 057. And the other trials was a Keynote 010. They definitely randomized the patients as per TPS scoring of more than 1%. Only those patients were included in the study who had TPS of more than 1%. And there was a OAK data definitely. Irrespective of PD-L1, patients were randomized. And the comparative arm in all the 4 trials was definitely docetaxel. Next slide. So there was a debate also why they took OS as a primary endpoint. Why should we use OS as a primary endpoint for the immunotherapy? Because we know that what they saw that even response rates were less in immunotherapy arm as compared to docetaxel. Docetaxel has higher response rates and sometimes it gives you a better PFS. But when they looked at the OS is always better with the immunotherapy. And we have, as said, we have 4 trials, and they also raised the bar. Now, now this decade, this time, I will be discussing the updated analysis. But at the primary analysis of these trials, they definitely the OS from 10.5 months immunotherapy gives us the OS of 12 to 13 months, and that was seen in Checkmate 017, Checkmate 057. Both 017 was for squamous histology, 57 was for non-squam histology, and Keynote was for both, and OAK was for both as well. So all these definitely 4 trials showed us the path that immunotherapy is a way forward to go when it comes to the second line after failure of a platinum doublet. Next slide, please. And definitely we have a consistent tolerance is an issue. So what happened when we use docetaxel? We see usually a lot of cumulative toxicity with the docetaxel. It is initially well tolerated. When we move on, it gives us a lot of toxicity, as is shown in randomized trials. And if you see the Checkmate, all these trials with the immunotherapy, grade 3, grade 5 side effects are like 8 to 15%. But with docetaxel, the grade 3 and grade 5 adverse effects are in the tune of 50 to 60%. Next slide, please. And symptom control is very important. Look at the slide to my left and see what is the improvement. With immunotherapy, we definitely see there's a lot of improvement in health status. And slide to my right, see the time to deterioration of health status. If you see the immunotherapy, there is really a time to deterioration is very less as compared to docetaxel. We can see time to deterioration with docetaxel at 12 months, what we see here in this graph. But once we see that the patient tolerates immunotherapy, and he can tolerate this immunotherapy for years actually without deterioration of his or her health status. So quality of life does improve with immunotherapy, what we have seen as compared to docetaxel. Next slide, please. Very important questions, which are open questions, are what is the importance of PD-L1 expression when we use as a second line therapy? Very important question. Should we do PD-L1 as a second line or should we not? And I think these are the next slide, please. These are the trials which have issued this question as well. So first we look at a Checkmate 057 and nivolumab data. And it definitely, they looked at the PD-L1 status, but PD-L1 status was only available for 50% of patients. But definitely they did see that the patients, the tumors having higher PD-L1 status, there is a OS benefit in such patients as compared to PD-L1 negative population. And very interesting data from Keynote 010, and patients having TPS of more than 50% have a survival OS in the tune of almost 15 to 16 months, and that's really great. And if we look at OAK data, also higher the TC3 and IC3 score, the better the OS as well as response rates, with a hazard ratio of 0.441. And this clearly shows that PD-L1 is emerging as a predictive biomarker also in second line setting. Next. And what happens to if the patient is PD-L1 negative, and how to use, can we use immunotherapy as a second line in such patients? And definitely we have data from Checkmate 5/7 trial, and we have a Atizo data as well. And here we can see definitely, if you look at the Checkmate 057 trial, patients who were PD-L1 negative, the duration of response was 18.3 months as compared to 5.6 months in docetaxel. Definitely a winner. Immunotherapy is a winner irrespective of PD-L1 status. And OAK data, Atizo data also showed that in PD-L1 negative population, there was a median OS of 12.6 months as compared to 8.9 months with the docetaxel. Next. One more question which is very important is duration. How long to treat? Should we stop at some point of time? Can we stop immunotherapy at 1 year? And next slide, please. And this was a data we got a signal what we got from Checkmate 153. They randomized patients to patients who responded. There was a randomization between continuous nivolumab versus stop nivolumab at 1 year, and what we saw that there you can see these graphs separating, and with the hazard ratios for PFS was 0.42, and 1 year PFS definitely was higher with nivolumab. When they continued further nivolumab beyond 1 year, there was a improvement in PFS irrespective of response rates, and there was a trend towards the OS. So definitely we should continue, I think, nivolumab immunotherapy beyond 1 year. Next, please. Again, one more question: should we treat it beyond progression? If patient progresses, we know very few options are there for us when patient progresses beyond, and what should we do then? Next slide. And Atizo data is very important and very interesting data. Atizo, they randomized patients. They had 425 patients in this study, and 7 patients who progressed, 78%. They were out of these 78%, 51% were continued on Atizo, and 28% did receive other therapy, and 21 did not receive any therapy at all. And when they looked at the survival of these patients, they definitely showed that Atizo post progression, the survival is 12.7 months. And the patients who did receive other therapy apart from Atizo, the survival is 8.8 months, and who did not receive anything, the survival is 2.2 months. And there's a debate also that the patients who didn't receive anything must have been very unfit patients. That is the reason they didn't receive any therapy. But definitely there is a data that immunotherapy can be continued beyond progression. Next. And hyperprogression is one issue which remains a concern actually, and different studies have shown that different hyperprogression rates, different incidence of hyperprogression. And you can see by Champet, Cato, and Sada, as well as Ferrara et al. Reported different incidence of like 9%, 6, 29, and 14%. It depends actually how you look. Are you looking for this hyperprogression or not? If you don't look at that, you might have less incidence. If you keep looking at that, one might see more and more hyperprogression. Next slide, please. And we next slide, we have our own data of hyperprogression. We checked next slide, please. And we looked at over 50 patients, and when we compared that tumor kinetics, we found that out of 54 patients had hyperprogression, and we did publish this. This is a published data, and out of 54%, that means we have 8% of hyperprogression, whatever data says. Next. And other question, which is like, what happens post immunotherapy when what will we do? What should we do post immunotherapy when patient progresses? And we have data of Doce and Nindatinib as a third line treatment after chemo and immuno. And definitely you can see Nindatinib and docetaxel does work. It works after immunotherapy as well, where you can see as patients who have prior IO had a better PFS of 5.5 months. And they have a disease control rate of 83%, and response rates of about 60%, which are very good as a third line. Next, please. And I will be discussing just a couple of 2-3 slides about long-term outcomes with nivolumab. We have now 5-year data available, and first I would like to present my data. What our center data, we have like reported initially a data of 20 to 25 patients. Next slide. What did we find? How it works? And we had an objective response rates in over 25 patients of 54%, and one complete response, and next slide, please. And what we looked at there, and in this our data, that we have a PFS of 15 months, 8 months, and overall survival of 15 months. Next. And let us see the now long-term data, where it leads. If you see this very interesting slide, that full data of survival from both Nivo trials 057 and 0017 data, you can see the very 13.4% surviving at end of 5 years. And if you look at the docetaxel, only 2.6% survive. And so there is 11% patients are surviving more with the nivolumab at 5 years as compared to docetaxel. Next, please. And I looked at this, what happens to 017 squamous data, which was nivolumab, and nivolumab was given as a second line for squamous cell. That is the 017 is all about. And definitely we can say at the end of 5 years, 12.5% OS versus 3.6%. And definitely this showed that 10% patients surviving more at the end of 5 years with nivolumab, and nivolumab is used as a second line irrespective of PD-L1 status. Next. And again, you can see separate 057 data when nivolumab was used for adenocarcinomas. Here also we have the separation of curves. So what is the 5 year? It was 14.0% versus 2.1%. What we see that 12% patients surviving more with nivolumab as compared to docetaxel at the end of 5 years. Next. And definitely they looked at also as a PD-L1 status, patients with PD-L1 more than 1% or patients with PD-L1 less than 1%. And if you look at less than 1%, the median OS is around 9.7%, which is not that great actually as compared to patients who had PD-L1 more than 1%. And there the OS is around 13.13 months, which is really great as compared to the docetaxel. Next, please. So this was my last slide, which showed that PD-L1 is an emerging biomarker. It is an emerging predictive biomarker, and in second line as well. So with this, I conclude my presentation, and thank you for patient listening. Thank you.
Thank you, Dr. Abbas. That was a nice presentation. Moving on to the next, I would like to invite Dr. Bhuvan Chog, who would be speaking on overall survival in HER positive, HER negative in breast cancer from dream to reality.
Thank you, Dr. Sumant, and thank you, Novartis, for giving me this opportunity. I hope I'm audible to everybody.
Yes, sir, you are audible.
So I'll just start sharing my screen now.
Sure, sir. Please do that.
Yes, Dr. Bhuvan, your screen is visible.
Okay.
Yeah.
Thank you. So the topic for my talk is the proven strategy to improve the overall survival in hormone receptor positive and HER2 negative advanced breast cancer patients.
Hello, check.
Am I audible?
Yeah, you're audible.
Oh, somebody said check in between. Anyway, so moving ahead, I think what this talk focuses on is evident to all of us. The newer molecule, that is CDK4/6 inhibitors, they're no more new anymore, but they are a strategy to improve the overall survival in advanced breast cancer. So before the CDK4/6 came in, I think we all know the armamentarium which was available to us. It was anastrozole, fulvestrant, and tamoxifen. What we used to do in our practice was we used to give anastrozole to patients who had limited metastatic disease. And then came the trial, Falcon trial, which said that fulvestrant is better than the anastrozole, and hence we started prescribing fulvestrant as the first line. And for both of for these patients who were unwilling for this or were not eligible for this, the drug which was there with us was tamoxifen. And then in 2015 and 16 came the CDK inhibitors, and in India they were launched in around 2017 and 2018. So how do these CDK4/6 inhibitors work, or why were they so effective in breast cancer? Was the CDK4/6 inhibitor are the so what happens is the G1 to S transition in the cell phase depends upon the retinoblastoma gene, and this retinoblastoma gene is under the control of CDK4 and 6. Once the cyclin D molecule combines with the CDK4 or 6, it leads to the phosphorylation of the retinoblastoma gene, and the cell is able to transit from G1 to the S phase. Now, what happens in a hormone-positive breast cancer is these hormone-positive breast cancer, or the breast cancer which are which are highly dependent on the estrogen receptors, they have a high prevalence of cyclin D, and they also have a promoter. The promoter of the cyclin D gene is also present in excess. So in short, they are excessively dependent upon the cyclin D CDK4 combination, and that is the reason efficient inhibition of CDK4/6 with cyclin D leads to such a degrowth or such a shrinkage of the tumor in these. What else does the CDK4/6 do is they increase the tumor immunogenicity for the breast cancers, and they bring about the PD-L1s, and they bring about the MHC molecules 1 and 2, which are efficiently recognized by the immune T cells, and it also leads to the dysregulation or decrease in the Tregs, and thus potentiating the anti-tumor immune response. So going forward, as we all understand that the drugs which are available to us in today's era that the first was palbociclib, then in India came the ribociclib, and now the third one which has come is the abemaciclib. Sorry for the busy slide. I just wanted to give a hint that these are the 3 drugs which are available to us. They are almost similar in their pharmacogenomics and as well as dynamics. Among the 3, the most potent which has been said is the abemaciclib, because of the inhibitory concentration which is required to inhibit the CDK4/6 is the least is required by the abemaciclib, and both palbo and ribo, they almost same on the other hand. What we need to understand is the selectivity of the inhibition. Among the 3 drugs, CDK4 let's talk about palbociclib first. Palbociclib is a drug which inhibits CDK4 and 6 equally. Then comes the ribociclib, which has rather significantly more selective inhibition of CDK4 as compared to CDK6. And then comes the abemaciclib, which among the 3 has the most selective inhibition of the CDK4 and among the CDK4 and 6. However, it also has a off-target inhibition of CDK9, which is primarily responsible for its gastrointestinal side effects. They all are excreted through the liver. They all are metabolized in the liver and excreted in the feces. They all are equally available. Oral bioavailability is good for them, and we'll talk about the adverse effects as we go down or during the further slides. So in what clinical settings can we use these CDK inhibitors? The 2 clinical settings which we end up using them is in the first line setting, which some of us like to call as endocrine sensitive disease. These are the clinical settings in which the patient has not been exposed to any patient who has presented with a de novo metastatic disease and has not been exposed to any CDK inhibitor or any endocrine therapy as yet. Or these are the patients who have been treated with adjuvant endocrine therapy but have relapsed after 1 year of stopping the endocrine therapy. The other setting is the endocrine resistant, in which the patient was being treated with endocrine therapy and now has progressed on that endocrine therapy, or has relapsed within 1 year or while being on endocrine therapy in an adjuvant setting. So to me, at least, the trials got a bit confusing. So I thought there has to be a simpler way to understand them. So I divided them as in these 2 settings. For the patients who are endocrine sensitive, or for the first line setting, the trials which is Paloma 2, Mona Lisa 2. Paloma is the palbociclib trial. Mona Lisa 2 is the ribociclib trial, and Monarch 3. So Paloma 2, Mona Lisa 2, and Monarch 3 are the first line trials in which the CDK inhibitor was used along with the AI. Mona Lisa 7 is a separate set of trial itself, or it's a separate trial in itself, in which the only pre and perimenopausal age groups were used, and the ribociclib was given along with AI or tamoxifen, and ovarian separation was added. In the endocrine resistant setting, there are another 4 trials, rather 3 phase 3 trials. We know of them are Paloma 3, which is the palbociclib that's Paloma 3 trial, the Mona Lisa 3 trial for the ribociclib, and Monarch 2 trial for the abemaciclib. So this is how I would like to, going forward, this is how I would want to divide the slides. And so this slide shows the PFS benefit which is available to us, and how this PFS benefit has transited to an overall survival benefit is what I'm going to focus on. So if you look at the PFS data which is available to us by all the 3 drugs, they are surprisingly similar. The hazard which is being shown by all these trials is around 0.5 to 0.6. There is a relative benefit of around 50 to 60% at a certain cutoff. All these the trials have different cutoffs for a PFS, but the hazard is around 0.5 to 0.6. However, it is in the overall survival data with which the difference start to come out. And I think that's primarily because the way these trials are designed, the population which these trials have included, and to some extent the drugs which are being used. So as we understand that, yes, PFS is important, but nothing beats overall survival when it comes to satisfaction to us as an oncologist. In a metastatic setting, if something can provide an overall survival benefit, that becomes an obvious first choice to us. And in the breast cancer, it's only very few trials or very few drugs till now have been able to provide this overall survival benefit. And rare thing has happened in the last 25 years that we not had much drugs to provide the overall survival benefit. The last I remember was the presence of the inclusion of trastuzumab, which has been a game changer, and now the inclusion of pertuzumab and trastuzumab, which has improved the overall survival in a HER2 positive setting. So it's the HER2 positive setting in which most of the survival benefit which has happened. The TNBC, Atezo, this has all gone to, it's all disappeared now. It's but as per the recent reports, Atezo doesn't work as good in TNBC. In HER2 setting, it's by the invention of these CDK inhibitors that we see this sudden jump or sudden advancements in the overall survival. So the overall survival data which is available to us at present is from these 4 trials. I'll divide these 4 trials into 2 sets. The first set is the Mona Lisa 7 trial. The Mona Lisa 7 is a trial. It's a phase 3 double-blind randomized study, which included first-line pre- and perimenopausal patients who have not been exposed to any endocrine therapy in a metastatic setting, who were treated with ribociclib along with the AI or tamoxifen along with an ovarian separation. The overall survival is available to us. The other 3 overall survival data which is available to us now is from the Mona Lisa 3, Paloma 3, and Monarch 2. This is a trial setting in which the patients have been treated in a second line, mostly in a second line, which are along with a fulvestrant with either of the respective drugs, as I've told you before. So what is present to us now is that there is, if you look at the data which is available to us in a Mona Lisa 7 trial, which I just told you, this is a first line pre and perimenopausal patients who were given AI or tamoxifen. As a surprise, I'll tell you later why it's now only AI, because the withdrawal for tamoxifen has been withdrawal. And as a matter of fact, in India, ribociclib was never given along with tamoxifen. So the ribo given with AI has led to a numerical advantage in a overall survival, and similar has been the case in a Mona Lisa 3. Moving forward, just to put the things in perspective, we have a Mona Lisa 7 trial. I'll just try to. So in a Mona Lisa 7 trial, we have at the end of 40.9 months, the median overall survival in a control arm was 40.9 months, and it was not reached in the patients who were on the trial arm. And a similar story was present in the Mona Lisa 3 trial, in which the patients, the patients who were on the trial arm, they did not reach a median overall survival, and it was around 40 months in the control arm. What happened was, in the Mona Lisa 7 trial, at the end of 42 months, the survival rate was around 70% in the ribociclib arm and around 41% in the control arm. So that gives at the end of 42 months, 3.5 years, almost more than that, there is almost a 30% reduced risk of death with the addition of ribociclib to the ongoing treatment. And if you looked at the AI subset, or if you looked at the subset in which the AI was given along with the ribociclib, the data remained almost the same. While if you looked at the trial in which the Mona Lisa 3 trial, in which the ribociclib was added along with fulvestrant in the first line or in the second line, there was still in both these arms, the overall survival benefit was shown. And now this is something which is a little different from what was seen in Paloma 3. The reason for that is not exactly clear, but the reasons which have probably come out of them is the Mona Lisa 3 trial. It included a set of patients who were given fulvestrant in the first line also. So probably that's the reason they were able to show a overall survival benefit. And in a similar state, however, they were also able to show a survival benefit in the patient who were being given fulvestrant or ribociclib in the second line also. So it's a bit different from the Paloma, and a bit of this may be because the ribociclib has a better CDK4 affinity than the palbociclib, and that is one of the reasons that how it's being it was a Novartis sponsored trial, but it was a trial which was it was dissected to be complete, and they were able to show a overall survival benefit. So just to summarize it, we have Mona Lisa 7 trial in which the median overall survival has not been reached, and the control arm had a median overall survival of 40.7 months versus not reached, and there is a reduction of almost 30% risk of death. In the Mona Lisa 3 trial, along in a first line setting, the median overall survival is not reached, and the reduction in death is around 30%. And similar was the story in the patient who was being given the second line. So what do I mean to say by all this is, we have these 3 drugs which are there with us. There is palbociclib, there is ribociclib, and there is abemaciclib. There is nothing which divides these three drugs. The 3 drugs have almost the same chemistry. Yes, they do have a different affinity to CDK4s and CDK6. So how do we choose in the clinical setup it's our problem. When a patient walks into our clinic, it's our duty as a clinician to understand which drug to be used where. Yes, I do agree that the adverse effect profile does have a role in it. Along with the adverse effect profile, there is the other thing which brings about is what is the comfort of the clinician. Each of these drugs have a certain amount of learning curve to it. Which drug is the clinician or the oncologist most comfortable with? And then there is this overall survival data, which obviously pushes us to choose a certain drug over the other drug. So let's say a patient who has walked into you as a premenopausal or a perimenopausal woman who has a metastatic breast cancer, and the patient is not in a visceral crisis. So if you look at the data which is available to us, it's only the ribociclib which has given you a good phase 3 double-blind randomized control data, which says that there is a definite overall survival benefit if you prescribe a ribociclib along with a AI or a tamoxifen along with the oral separation. Now, if you talk about in a postmenopausal woman who has metastatic disease, advanced breast cancer, and you would want to give them a CDK inhibitor, again, all the 3 drugs are available to us. We can choose any of them. There is no one winning over the other. There is no one winning over the other, and probably we would end up choosing them as per our comfort and as per the adverse effect profile. If the patient has a cardiac comorbidity, I probably may not choose a ribociclib and I may choose a palbociclib. If the patient has a GI upset, I may choose I may not choose a abemaciclib and I may end up choosing a ribociclib or a palbociclib. The other subset is the patient in which we want to use a fulvestrant as a first line. And a patient in which we want to use fulvestrant as a first line, again, the data which is available to us, which has provided an overall survival benefit, is Mona Lisa 3, in which there is an overall survival benefit with addition of ribociclib to fulvestrant in first line as well as the second line. So again, if you look at the health-related quality of life parameters, both in the either of the 3 drugs were unable to improve the quality of life as compared to the control arm. However, the quality of life or health-related quality of life was certainly improved in Mona Lisa 7 trial in a pre and perimenopausal woman with addition of the CDK inhibitors. So just to summarize, we have ribociclib, which is a CDK4/6 inhibitor, which has shown a overall survival benefit in 2 phase 3 studies. it has shown that there is a certain delayed time to chemotherapy. And there is a, in the Mona Lisa 7, it showed that there was an improvement in the quality of life, including pain and fatigue. Now, coming to the adverse effects, I would just like to bring about that we have these three drugs and the adverse effect profile is different. The the two drugs which were known to us earlier were Palbo and Ribo. The drugs which we all understood, which we have all given them enough time to understand that there is a neutropenia to it, and this neutropenia is more of an innocent neutropenia. It will not do anything to you. It's only in 1 to 2% that may cause a febrile neutropenia in Palbo, and in less than 1% in Ribo, it may end up causing a febrile neutropenia. We all understand that it is not the apoptosis of the cells as in chemotherapy, but it is just the stasis of the neutrophils in a premature form. And the moment we stop the drug, the neutrophil starts to regrow. And we have all understood how to manage these neutropenias. The Abema has come into the market in recent months, and I think as for personally, I have started using Abema in one, but I would like to have a learning curve to it. It's still my learning curve as far as Abema is concerned is going on. The patient do get a few diarrheas to begin with, and we all have a certain learning curve to each of these drugs. So how do we end up choosing these drugs in clinic? Is we look at the patients and we decide which drug to give. If a patient if the patient has a cardiac comorbidity, obviously we would want to avoid ribociclib. If a patient has a GI discomfort or has a inflammatory bowel disease, we would obviously want to avoid abemaciclib. Now, with the hepatotoxicity, I think it's the ribociclib and the abemaciclib, these are the two drugs which are generally associated with hepatotoxicity. The hepatotoxicity is not immediate. The median time to onset of hepatotoxicity in ribociclib is around 2.5 months, and it takes another month for it to settle. With abemaciclib, the median time to onset of hepatotoxicity is around 1.5 months, and it takes around half a month to settle. So we all have these drugs. We all need to understand how to play with these drugs. It's with experience that we all learn that. And all of these three drugs, they all are CYP inhibitors. They all are metabolized by the cytochrome P oxidase. And now, so we need to be very cautious while we are giving patient cytochrome CYP inhibitors or CYP inducers. For example, the ketoconazoles or if we were giving, for example, we are giving ondansetron with the ribociclib, we need to be cautious about the prolonged QTCs. So what we need to do is we need to monitor early. And so each of what has been done great by the companies these days are that they tend to educate the oncologists before they bring in the drug. Like for example, Dr. Jyoti ma'am, when she was telling us about the PIK3 inhibitors, there is a certain amount of literature which is available to us now. And how do we manage? So in a similar manner, we have a certain amount of literature which is available to us as far as these drugs are concerned. For example, in the ribociclib arm, for the ribociclib, it's generally said that you start with CBCs at the baseline and CBC at mid-cycle around day 14 for the first cycle and the second cycle. And from third to sixth cycle, you can start, just at the start of the cycle, you need to do a CBC, basically the blood parameters. ECGs are done generally for the first, we generally do it. What we do is we do it similar to the blood counts that the patient come at the baseline and the mid-cycle for first 2 cycles, and then at the beginning of the cycle for another 3 to 6 cycles. Now, what has happened is all these drugs, they obviously require dosing modification, and it has been proven to us that even if we reduce the drug, the efficacy of the drug or the effect of the drug reduction, the PFS doesn't happen. The PFS is maintained while even if we reduce the dose. Now, what is good about a ribociclib is the dose reduction is easiest. The tablet comes as a 200 milligram. So the patient doesn't need to come to you to get a repeat prescription. So if you're giving a palbociclib to somebody, if you're giving them a 125, the patient would need to walk into your OPD again to get a 100 milligram prescription if you want to reduce the dose. However, for ribociclib, the things are pretty simple. They have been taking 3 tablets of ribociclib. They just need to cut down to 1 tablet, and then they will be able to manage it. So I think the dose reduction or the convenient dosing it's a plus point for ribociclib. So I think I'll be finishing the talk. To summarize, we have good amount of data available. I think choosing the right drug for the right patient is where we need to master our clinic. Thank you.
Baba.
Hi Shivam, I think you can proceed with the next session.
Hello, Dr. Shivam.
Yeah, thank you, Dr. Chug. Now moving to the next, we would be having a panel discussion. The moderator of the panel would be Dr. Prashant, and he would be speaking on the topic would be HER2 plus breast cancer in 2020 new challenges. Over to Dr. Prashant. He would be inviting his panelists.
So I hope everybody can hear me now because there was some technical issue with the sound earlier.
You are audible, sir. Perfectly
I'm
fine.
audible. So I'm so happy to know that. Thank you so much. So okay, so everybody can see my slides now.
Yes, sir, visible.
So just the previous Bhuvan's talk was very nice actually. I just wanted to just add one comment. Probably the OS advantage. Bhuvan mentioned that the OS advantage is only with ribociclib, but what I understand is probably Monarch 2. It has also showed a 9.4-month OS advantage with Abima, fulvestrant and Abima. Just
Prashant, can you bring the speaker nearer to you, the mic nearer to you?
So is it better now? No?
Yeah, a little better, Prashant.
Little better. Okay. So let me try doing the audio settings. I think it can't be better than this. Is it okay? Am I audible now?
Yeah.
It's okay, sir. Yeah.
It's okay, fine. So let me invite my illustrious panelists. I have been, I have moderated a session with some of them earlier also. Dr. Anjana Joel is there. I can see her. And I would request everybody to be on video for the panel, please. Huh? So Dr. Rajit Chandna. Yeah, thank you so much. So Dr. Nagendra, I can see now. Yeah. Where is Rajit? I can't see.
Sir.
Rajit is there. Yes, I can see him now. Good, good. So, and Dr. Aditya Murli.
Yeah, hi Prashant. Thanks for having me here.
Dr. Aditya, how are you? And Dr. Robin Kosa now.
Yeah, I'm here. Hi.
So, Dr.
Prashant, one request. Robin
yes.
sir has been saying that what is the role of radiation oncologist? So his role has to be defined.
Okay. No. There is a definite role of radiation oncologist. The radiation oncologist is, the backbone of any oncology center and any oncology moderation or panel. So, so we do understand that the prognosis of HER2 positive disease, breast cancer is generally poor without all these agents which we have now. We have so many agents, and you can see that it does make a difference. So adjuvant trastuzumab also, improves DFS and OS in HER2 positive, early breast cancer. And this is some of the early data. The HERA study, BCIRG 006. Everybody's kind of, well aware of these now. So this is one case which I'm sharing with my panelists. So this is a lady, a 40-year-old premenopausal lady with a right-sided breast cancer and, hormone receptor negative, HER2 3 plus, PT1C, and CN0 and N0 and M0. This is post-surgery actually. She was operated. I just wanted to pose one question to my panelists. What kind of adjuvant strategy they're going to follow? So let me ask Dr. Aditya, who is one of my favorites. Tell me, Aditya, what are you going to do now? You operated this patient. This is a PT1C N0 M0 tumor. Aditya, I can't see you.
Okay.
You're not on video. I want to see your expressions when you talk.
Okay, thank you.
Okay.
It's Saturday night. My expressions might be.
It looks like you have lost some weight also.
I have lost some weight. I've gained a little bit of spirit. So,
Great,
in the spirit of all of this, so uh,
So
see,
tell me.
of all of this, no, I would still, since it is T1C, there is a definite role of trastuzumab also in this. So maybe TCH into 6 followed by trastuzumab for 1 year, please.
So now, Dr. Anjana, can we have your opinion now?
Sure. So I also probably
all
would
these
go along the
options?
same lines.
You're going
The
with
TCH.
you're going with option
So
A.
no, option A, it says H for 6 months. I would offer
Okay.
for 1 year.
Okay, so
Okay,
you're going
that would still be yes.
with 1 year.
That
1
would
year
still
of,
be the chemo backbone would be the same based on the BCIFG006.
You want to go for 1 year of trastuzumab. Okay, Dr. Nagendra.
Yeah, I do agree with Dr. Anjana. TCH for 6 cycles followed by
want to give TCH.
certain for 6 months. We are well aware about Persephone trial when 6 months was used, but even then I will go ahead for 1 year if
you want to go for 1 year.
If affordability is not an issue.
Any different opinions from anybody else, like Dr. Rajat and Dr. Robin? Do you feel differently about this? This is a PT1C and zero tumor, EBC.
My choice would also be the same, TCH followed by 1 year maintenance.
Okay, so everybody kind of feels the same. So what does the data say? So what do you feel about this kind of a strategy? APT trial. This was an important study. So Dr. Anjana, you have anything to say on this, the APT study?
Sure. So I mean,
this is
in
for
terms
smaller
of
tumors, less than 3 centimeter, and later on, modified to include those with a micrometastatic N1 disease as well.
yes, so our patient could also go under this APT sort of a regimen as well.
Okay.
But considering the fact that she's also ERPR negative, I mean, I would discuss probably the TCH into 6, and if somebody is really reluctant.
You are not happy with a 7-year DFS of 93.3%?
Of course I am. Of course I am. Okay. Of course I am. So this would be one option. I'm not sure if I saw this option in the previous slide.
Okay.
Yeah.
You did.
Okay.
Did?
Okay. I'm my bad. Sorry.
No problem. There were many options actually, and that very well delineates the complexity of adjuvant and neoadjuvant treatment in HER2 positive tumors now.
Dr. Prashant, can I intervene? Can I intervene?
Yeah, you can definitely.
Yeah, so the big issue here, it's a 40-year-old lady. It's a premenopausal lady who is ERPR negative.
Okay.
I would err on the side of caution. So I know
So
APT APT is standard of care. There is no doubt, and I have also included Pacley into 12 as a part of my own clinical practice. But in this particular setting, because it's a premenopausal lady, because the ERPR is negative, I still want to go for a full-blown TCH.
Okay, so what about this kind of a strategy? So the newer drugs, TDM1 is also there now. A single drug for 1 year.
Oh, this is.
Does it sound rational?
This is This sounds very rational to me. No doubt in that. But this is phase 2 curative cancers. I would want strong phase 3 data and years of experience before I even try and attempt this.
Great. Rajat, do you have any comments?
So I think I would say that both Tolene regimen and TCH, they both are standard. So it depends what we are comfortable with as a clinician. So I would still go with TCH. And regarding this data, it's a phase 2 data. I'm still able to digest the Catherine data. So it will take some time for me to digest the data.
Let me add to that. This was not a positive study. This did not show any benefit or less toxicity with TDM1. So you are right, not choosing TDM1. So, do you believe in neoadjuvant treatment? All 5 of you. Robin, do you believe in neoadjuvant treatment of HER2 positive breast cancer?
As far as the practice is concerned, I think with the receptor, I think this is ERPR. If I'm not sure, ERPR
this is
negative.
Hormone negative HER2 positive.
Hormone negative, yeah. It's a practice. I think
that's the setting I'm asking for. So we don't have a surgical oncologist in this panel, I believe. So
and his belief and the surgical oncologist's belief is more important than everybody else's.
Is it? Is it? Is it, Aditya?
Oh, because early breast cancers more often not do end up going to surgical oncology. So as long as surgical oncology is not on board, no matter whatever data we present, yeah.
Then we will get them on board definitely one day. So this is the CT neo-BC analysis, and the patients who had PCR, the HER2 positive ones, they had an HR for OS which was favorable, 0.34, and the CI is a 0.24 to 0.47. It is significant, and there is a significant increase in PCR when we utilize, a combination of HER2-based strategies in adjuvant and neoadjuvant setting. So there seems to be an association with good outcomes with utilizing HER2 directed therapy. So is there a subset of patients who you would definitely ask for neoadjuvant? You're a surgeon and you're sitting in a tumor board. Okay, you are discussing a patient, and would there be a subset which you definitely would want to go for NACT? So Dr. Nagendra.
Yeah, definitely. All those patients who are having a high nodal positivity and tumor size greater than equal to 2 centimeters or about T2 disease, they will be the very important candidates, and we will contemplate neoadjuvant chemotherapy as the pathological CRs will be higher in those patients.
Would there be any patients for whom you will definitely insist for NACT? You will debate more than you would for another subset.
Right. So high nodal positivity. Along with that, if the patient is having size greater than 2 centimeters,
okay,
those patients I will prefer neoadjuvant chemotherapy.
So would hormone status also, reflect in your choice, or would decide, would be a decisive factor in choosing your strategy, the hormone receptor positivity or negativity?
Right. So if the patients are having a hormone receptor negative, HER2 positive, these patients like
let's say the patient is hormone positive, would it change your decision?
Hormone positive, and suppose the patient also is having a high nodal positivity also, even then we will contemplate neoadjuvant chemotherapy.
You will contemplate, okay.
Yeah, along with anti-HER2 drugs.
Great. So these are some of the studies where NACT was utilized. These were phase 2 studies, Neosphere and Trifina. I'll just show you the PCR rates here. And this is basically with the backbone of trastuzumab and pertuzumab, a dual HER2 blocking strategy, with or without anthracycline. Just look at the PCR rates in the intention to treat population. This is with neoadjuvant trastuzumab with chemotherapy. So it does show that the PCR rates are increased. With THP, you can see 45.8% in this data set. And look at the Trifina data in patients who are ER and PR negative and received 6 cycles of TCHP. The PCR rates are very high, very good, 83.8% in this subset. And even in the hormone positive population, you can see that the PCR rates are pretty decent, and about more than half the patients are achieving a PCR, which seems to be a reasonable endpoint. So coming to the adjuvant treatment. So this is another patient. This is a 40-year-old premenopausal lady again. This is again hormone negative, HER2 positive, and it's a clinically T3 disease and 2 disease, and again was operated. This you discussed in the tumor board vehemently, and the surgeon did not, and the patient said, okay, I'll go with the surgeon, get operated. Now this patient is coming to you. What are you going to do? Aditya. Aditya, are you there?
Yeah, I'm sorry, I had muted myself. So if I did get a choice, to convince the patient and finances out of the option, TCHP into 6 followed by HP into 1 year for sure.
Dr. Anjana.
Yeah, so this is a patient for me. If I would actually want to give this patient the benefit of anthracycline, so I would probably opt for an AC and TH and trastuzumab for 1 year. I would maybe discuss pertuzumab with them, but this is not a patient where I would skimp on the anthracyclines, especially because she has M3 disease and she's hormone receptor negative.
So you were saying that in the adjuvant setting, you don't prefer to use HNP together? You don't prefer that?
Not
you
really.
Prefer anthra over it?
Not really so much. The thing is, in my practice, anything more than T2, at least what we follow here, anything more than a T2 and any node positives go for neoadjuvant. So we don't really often face this unless somebody's operated outside, and most of our patients can't really take pertuzumab. So then we end up at least giving them the anthracyclines and this.
Sounds like a reasonable strategy. Patients who can't afford can possibly get anthra. So Dr. Nagendra,
Yeah, I
would
do.
choose,
Yeah.
what would you choose?
So my option will be TCHP for 6 cycles, followed by HP for 1 year. As the patient is having a high nodal positivity, we can use pertuzumab if affordability is not an issue. So if a patient is not affordable, then what Dr. Anjana have told, absolutely right.
So this is the data set which is kind of guiding everybody to utilizing this adjuvant dual HER2 blockade in this setting. And this was post-surgery randomization between chemotherapy, trastuzumab, pertuzumab versus chemotherapy, trastuzumab, and placebo. And primary endpoint was again this is a very commonly used endpoint now in breast cancer, IDFS. So this was these were the results. Look at the updated analysis here. Year 6 is 90.6% versus 87.8, about 3% delta. It looks very
So
small.
Prashant, I mean, numerically, sorry, go ahead.
Yeah, you can, if you want to add something, go ahead.
No, I'm saying in our sort of a practice for this sort of a numerical benefit, when you look at the cost effectiveness and when you look at the toxicity of pertuzumab, with a significant proportion of patients experiencing pertuzumab related diarrhea and those sort of things, maybe it is something which you have to discuss with the patient and then sort of decide if they really want to go ahead with.
I'll come to the next slide now. So what does this change anything in the node positive cohort? The difference is more.
Probably not. Probably not. It's slightly more. It's more, yeah, but it's slightly more. It's to the tune of say 4%.
Okay. So Aditya, any comments?
So sorry, yeah. So the thing is, all of this put together, I mean, this data has also been in front of regulatory agencies, and UK NHS also had considered this data, and keeping this data in mind, they tried to use something called as QALY, so quality adjusted life years, and the benefit of pertuzumab versus cost benefit, and all of these put together. I do agree and understand with Dr. Anjana that. We cannot extrapolate data of different countries, but even economically speaking, when you try and implement QALY in this setting, pertuzumab has got approval by NHS, and I mean, yeah, but it is definitely, I would say that it is definitely worth discussing with the patient, and obviously once the patient decides, that's what we do.
Okay, so what I understand is from the panelists is cost is the barrier.
Just a comment. There was a statement said we discussed with the patient. We tell some, but patient at 3 years your expectancy is 90%, and with pertuzumab it's 92%. Do the patient change their mind by just this 2%? If you really tell them this way.
So any comments on this question by Dr. Robin and Dr. Anjana?
I mean, no, sorry to interrupt here. So, Dr. Abin, so see, statistics hides as much as it wants to and reveals as much as it wants to.
Why actually I asked this question in our tumor boards when we discuss the pertuzumab, and we generally have a feeling that our surgeons say that they don't find too much benefit of adding pertuzumab. Yes, the data does show advantages, but in practice they don't find too much benefit of that. So that's the reason I'm asking.
See, all said and done, this is probably not a scientific debate. Scientifically, head and shoulders pertuzumab wins because 2% or 3%, we don't know which patient lies in that 2-3% extra population, and if they do lie in that, for them it is 100% or 0% of cure or having a recurrent disease. So scientifically, this is probably not a discussion, but of course, economically, it makes a lot of difference. I do work in a setup wherein I have the luxury of discussing this. I do understand that most of my partners don't, and then I really respect that.
Let me cut you short, Aditya, on this. You are very right that in a subset of patients who are node positive, the difference is more, and who have heavy nodal disease, they will probably benefit much more. So they could be candidates, but yes, cost is a barrier. So as rightly pointed
Prashant,
out by Dr.
hi.
Robin. Yeah. Anjana.
So, I mean, for me, if this patient had to take pertuzumab, she should have ideally taken neoadjuvant pertuzumab.
So
now,
has,
the boat
she
she's
has
missed
not,
totally.
So now.
Yeah, that's what. So she's missed that boat.
Yeah.
So she's missed that boat.
So
now, I mean, I agree. So if she's somebody who can understand what a 3% benefit is, yeah.
So this person definitely has missed the boat, but now she has come to you with a heavy nodal disease. So are you still going to let her off without the best treatment?
Oh
That's
no,
the
of course
question.
not. Of course not. We would discuss it with her, provided she could take it. Now, if she can't take it, the next best option is what she has to take, which would
So
be a
let me come to the
anthracycline
third case,
based
which
followed by
actually,
1 year.
which let me come to the third case, which actually you managed in your center, and she actually was convinced by your thoughts on neoadjuvant. This was again a similar scenario, a T3N2 disease clinically, and you want to choose the neoadjuvant chemotherapy now. Now it will be interesting to know your insights on this. Tell me which option you're going to choose.
Sorry, how old was she post
This is
premenopausal
a 40-year
ERPR?
40-year-old lady.
Okay, ERPR.
So it's a hormone negative, HER2 negative, as the previous patient's profile. But
okay,
this patient has come to you for neoadjuvant, and you're going to choose a neoadjuvant backbone now. So out of all these, what are you going to do?
so for me, in terms of choosing a neoadjuvant backbone, I would go for option E, where I would give her a TCHP for 6 cycles, and then I would do the surgery and sort of decide based on her histopathology as to where she goes in terms of her maintenance anti-HER2 therapy,
So
TDM1 versus 1.
let me come to Rajat now. Rajat, tell me what are you going to do?
So I think theoretically both C and E are the options, but I will choose with the option C. Uh, I would like to give her the exposure of anthracyclines and then would follow trastuzumab and paclitaxel. TCHP I think would be too much. We can decide after the surgical report regarding adding TDM1 or not.
So nobody is for TCH?
I
Nagendra?
mean, if there is no money, then I am for TCH into followed by, or I mean, option A, because see, ultimately in a HER2 positive disease, and we are thinking of, and a high nodal positivity, we are thinking of neoadjuvant therapy. I think withholding the benefit of trastuzumab from a patient right from day one, probably clinically might be inferior.
So one more thing,
Dr. Anjana
can
would
I
have
add one
comments
thing?
on that. Yeah, sure, go ahead.
So if the patient is affordable, I will go with option E. If the patient is not affordable, we'll go with option A will be a preferred option. But the only point here is, I just want to add one more caveat that we have used TCHP many a times, but I will like to compromise the dose of carboplatin in that case. Majority of patients are having toxicity because of carboplatin. So you can use modified doses of carboplatin and go ahead with TCHP if affordability is not an issue, followed by surgery, followed by whether the patient has achieved a pathological CR or not. Then you can add TDM1.
So this patient is continuing treatment with Dr. Anjana now, and she has is in the clinic seeing the post-operative report. It's PT1N1M0. So now what are you going to do? You have given TCHP 86.
Yes.
The patient has got operated.
Okay, so definitely we would discuss TDM1 with her as a maintenance anti-HER2 therapy, and the order of discussion would probably be TDM1 and HP followed by trastuzumab alone. Okay, that would be the sort of sequence of how we would discuss our preferences, and then we would sort of allow her to take her choice. Obviously, observation is not a feasible option.
Aditya.
Agree completely with Dr. Anjana. I mean, that would be a sequence in which I would also discuss.
Okay.
Just to add something, Prashant, on the previous discussion. So for me, the only question is that she was initially N2. So how comfortable are we to avoid an anthracycline in somebody like her, especially if you are going to, give her only trastuzumab? So are you okay with just giving her carboplatin and trastuzumab and a taxane and giving off 6 cycles in an N2 disease?
Aditya is going to answer that. Aditya, tell me, are you okay with
So end of the day, the discussion is do we? I mean, by giving anthracyclines, we are delaying the introduction of trastuzumab in a heavy nodal positive disease.
No, you can do the taxane and trastuzumab upfront and then do the anthracyclines.
But nevertheless, there would be a break in. There would be a break in
Dr.
that.
Anjana, let me ask you, what are you going to start off with? You start off with anthra, or you start off with taxanes with the trastuzumab?
We usually do the taxane and trastuzumab for 2 months, and then we do the anthracyclines. That's what we do.
So there you have your answer, Aditya.
My experience in that is limited, so I would defer to Anjana's expertise on that.
Okay. So this is the data set which is something which has changed the treatment paradigm, and has brought TDM1 to the fore. So these patients who had residual disease post neoadjuvant chemotherapy, HER2-based neoadjuvant chemotherapy, they were randomized to TDM1 and versus trastuzumab, and the primary endpoint being IDFS. And this is the data which the panelists are so happy about. And most of these patients, you can see they received trastuzumab alone, so about 80.8%, and about 17.9% only were there who actually got something different in the preoperative setting. So this is the IDFS advantage. So Dr. Robin was very keen on talking on numbers. So are you happy with these numbers now? Tell me.
Yeah, look like slightly impressive on the graphs.
Or dil mange more.
How
much is more?
Relatively better. Everything in this word is relative. Yeah, relatively slightly better.
So you're not happy with 12%?
No, obviously that's obviously better than the previous.
Okay. So talking of numbers, Dr. Anjana, are you happy with this?
Oh, definitely. Because this is as good as it gets for that population of patients who, remember, we are sifting out the ones who have had a pathological CR. So we are choosing the worst of the worst, and this is those patients who are getting this. So in these patients, these are patients we know are at a higher risk of recurrence. Okay, and definitely, yeah.
So
this is good.
Yeah. So somebody got too happy. So he tried to test another combination of TDM1 and pertuzumab. And just imagine what the cost is going to be in the Indian setting. TDM1 and pertuzumab together. And I thank God for the result. It was not a positive study. Otherwise, it could have gotten FDA approved, and we would have some more discussions to follow. And Dr. Robin would have had probably something more to say on this. And the surgeon who works with Dr. Robin, they would have been very unhappy about the results. So that's just besides the point. So this is.
May I add something?
Yeah.
So in patient who had neoadjuvant trastuzumab and pertuzumab, the Catherine trial, the patients who had some residual disease, there was a non-significant trend. So maybe those patients who have received pertuzumab as NACT can continue with the same regimen.
So you're saying that they can continue with you're saying they can continue with trastuzumab alone? I didn't get you.
Trastuzumab plus pertuzumab.
Plus
if they have
pertuzumab. Okay.
the same as NACT.
So Dr. Anjana, are you okay with doing that? Considering
Probably
the cost
not.
of H plus P?
Yeah, probably not, because it's probably
somebody who has residual disease, somebody who
yeah,
who doesn't have.
In somebody who has residual disease, I think cost-wise, if somebody can afford TDM1, I'm sure they can afford pertuzumab and vice versa. Definitely. So I would definitely discuss TDM1. So that's a no-brainer. So, now, if somebody does have a PAT CR, now that's a discussion which is kind of difficult. I would probably drop the pertuzumab and just continue the trastuzumab alone.
That's the reason, and that's probably what
Prashant, I think I'm just barging in for this lovely panel discussion.
How much time we have now?
No, time is not a problem. I think nowadays dinner is not being served, and other people will log out in the last panel.
Okay. Tell me, Suman, what do you have to say?
With this combination is the lung toxicity. So in last 1 or 2 patients, the problem which I faced, which was a true problem, was when you are giving a combo, the problem of lung toxicity is a real world problem. I don't know how many, because you are a person who gives a lot of fancy drugs. So what is your take on the lung toxicity in these groups?
You asking the moderator? You can't.
Moderator is the one who is supposed to answer. No? We are the poor panelists and the outsiders.
So let Dr. Aditya answer this one. Aditya, what do you have to say on this?
Yeah, Aditya should answer.
Fancy drugs.
So no, so I know. Okay, no extracurricular discussions here, but I've used this combination in 3-4 patients, and to be honest with you, they have done wonderfully well. Every single one of them has achieved a PAT CR, and all of them are still doing well. So personally, I don't have any complaints. And to echo what Dr. Anjana said, we have thrown the kitchen sink at the patient by adding both trastuzumab and pertuzumab in the neoadjuvant setting. And in spite of that, if there is a residual disease. I think the patient has got a bad biology. We need to change tracks and add something else, and TDM1 would be apt in that setting.
So yeah, so that's pretty much been my experience too. It's well tolerated. I've not seen much toxicity and very good PCR rates, echoing Aditya's thoughts. And these are the approvals. You have niratinib also as an extended adjuvant treatment. Any thoughts on this? You know, this is for the hormone positive, HER2 positive subset.
Not had the opportunity to use naratinib. Don't think I am too excited to use that. I've not heard good things regarding the tolerability of this drug.
Well, that's what we
From
get
what
to
we
hear
hear,
from
I
both.
think it's a horror to use. Yeah.
It's quite a toxic
It's
drug.
kind of a horror to use mainly. Yeah.
Yes. So the toxicity, literature is more than the efficacy literature.
I think that's very aptly put. Yeah.
Okay. So what do we do eventually? Does this seem like a okay strategy to you, Dr. Anjana? The more than T2 and N1 disease, they get neoadjuvant TCHP, or what you said, anthracycline based backbone, and then based on the residual disease. So do you have some patients in your mind who you're going to fight for with the surgical oncologist that yes, these patients should get neoadjuvant? Is this that subset?
Actually, you know what? I'm really privileged to work in a place where I really don't have to fight with the surgeons here, because we've managed to convince them about the benefit of neoadjuvant treatment in HER2 overexpressed and triple negative breast cancer.
Let me put it straight. I'm talking of an intellectual fight.
Okay. So that's what I'm saying. So in an intellectual fight, so I would fight for patients who are more than T2, and of course who are more than anything more than N1. So most node positives go for neoadjuvant treatment in some form, irrespective of
who are the patients who straight
whatever.
away go for? Who are the patients in your center who straight away go for surgery?
Okay, so that's a great question. So so obviously everything depends on the hormone receptor status. So most triple negatives and HER2 overexpressed who come to us are at least T2N0, if not more. So the minority who are say T1N0 triple negative or HER2 overexpressed are the only ones in these two subsets who go for any sort of upfront surgery. Anything more than that, probably or most likely go for neoadjuvant unless they have a lot of comorbidities, and then we want to minimize toxicity and they go for upfront surgery. Now hormone receptor positive also, I mean there the decision making is slightly more complex because you have premenopausal age, postmenopausal, a lot of neoadjuvant hormones and that sort of setting. But in these two high risk subsets, that's essentially how we make our decisions.
So this is what the summary also says. Dr. Anjana has already summarized. For the smaller tumors, we still have the option of using the APT regimen. And neoadjuvant is a strategy for node positives and the T2 tumors. And this is the data. The affinity is for the adjuvant treatment, and Catherine, the better looking data overall, and Extenet, which with a toxic drug, not very convincing for most clinicians. So in the metastatic setting, this kind of a result is what has been the most impressive in the last few years. The OS benefit and relatively safer toxicity profile of this combination, the Cleopatra study everybody is aware of, but we have got better. Now in 2020, 2019, we have got some newer drugs, and we are going to probably look at these. So Dr. Aditya, what are your thoughts on these newer drugs showing up on your screen?
See, the data on trastuzumab deruxtecan is actually fantastic, because the trial, I mean the trial which got the approval for this drug included the patient subset who had progressed on pertuzumab and TDM1. So this is probably a drug which I would be itching to get my hands on. We do unfortunately get such patients in our, in our setting wherein who have progressed on pertuzumab and TDM1. So that is quite impressive. Neratinib, I'm still not very convinced. Tucatinib has got fantastic data both in this year's ESMO and this year's ASCO. So these two drugs are the ones to look out for.
So Dr. Aditya visibly is pretty excited with the newer anti-HER2 drugs. And this is some data with neratinib, just to warm up. So this showed good, kind of reasonably good CNS efficacy, and CNS overall response rate was even there, even with prior exposure to lapatinib. And this was the Nefertiti and the Nala studies, and this is what these actually showed. So this is a patient now. This is a KT, a 60 years old lady. She has a kind of HER2 3+ disease, hormone negative disease, and had metastatic disease at baseline. She was treated with the Cleopatra kind of approach with the THP for 6 and HP maintenance kind of strategy. She progressed, then got TDM1, and now we are in 2020. So we are not going to talk of second line. Going to talk of third and fourth line now. So 6 years she did well. So now she has brain metastasis, but she has only 3 lesions, and also had some progression in liver. So let me put this question to Dr. Robin now. What are you going to do? This patient has come to your clinic with 3 brain lesions, small brain lesions, and some small bit of liver disease. It's not a high burden disease.
Oh, it's not.
Patient is also
So that's.
stable. Patient is doing well. 6 years, she did well with this kind of medical treatment. Now,
That's the point. If the patient is stable, the burden of the disease extracranial is very low. So maybe 1 or 2 lesions in the liver, and then I would strongly consider the. And since there is 6 years of disease-free interval between, and we have a long list of your so many drugs already in the chain. So I'll err on the side of doing, if the lesions are small, go for an SRS for all these 3 lesions, and watch rest. The visceral disease should be taken care of
so now we have entered the fancy space of radiation oncology.
You
And
need to
Dr.
leave
Robin seems to
something
be
for the
very-
radiation also, no?
Absolutely. So now Dr. Robin has done SRS for these 3 lesions, and he has done something for liver also. Managed all the oligometastatic disease. So, and the patient was doing well on HNP. So the patient now goes to Dr. Anjana's center. Now let us ask what she's going to do. Patient is sitting on in your OPD in front of you, asking, "Ma'am, tell me."
Okay. Okay, so now again, this is a patient where definitely we would discuss locoregional therapy for the brain. Now, in terms of what locoregional therapy it is, I think it depends on the location of the brain
The
mets
patient,
and also
the patient has come. The patient
yeah.
has come after visiting Dr. Robin and has completed the local therapy already. Now she's sitting
Okay,
sitting in
sure.
front of you after getting the SRS and local therapy to the liver done. Now what are you going to do?
Okay, so I explained to her that there are a lot of drugs which ideally she should be getting in the order of say trastuzumab deruxtecan and tucatinib, which probably are the best for her, which currently I really don't have access to. So in that sort of a setting, I would probably just give her capecitabine and lapatinib, which is at least available here.
So Dr. Aditya, now Dr. Aditya is sitting somewhere where he has access to both, and his hands were very itchy, so he got hold of tucatinib and TDX. So what are you going to do, Aditya?
So Prashant, my hands are full right now with something else, and I am not sitting at a place with either of these. Nevertheless, if I do get access to either of these, trastuzumab deruxtecan has had a fantastic run both at this
So
year's
you
ASCO
seem
and
to be
ESMO.
more inspired by TDX rather than tucatinib. So let me show you some data.
Yeah.
So this is the HER2 climb study. And this was a randomized double-blind study, placebo-controlled again. So CAPE, trastuzumab, and tucatinib versus CAPE, trastuzumab, and placebo. So Dr. Anjana, do you see something here which is missing? Or would you have added something to the study to make it more convincing?
So I would have at least compared it with capecitabine and lapatinib, or something else along those
So you pointed out very rightly that CAPE, trastuzumab with lapatinib could have been a comparator. Am I right?
Yeah, yeah.
Okay. So still with this kind of a approach, the investigators were able to find some reasonably good survival benefit. This is the median PFS and the hazard ratio looks impressive, 0.54. But the good part here is the risk of disease progression was definitely reduced with this kind of approach. 46% reduction in disease progression. And just look at at these time points at 12 months, the patients who were alive and free from progression, they were 33% versus 12% in the placebo arm. So looks something reasonably good. And when you look at the CNS efficacy, the CNS efficacy was also very decent, and it looks like a very CNS active drug. So and coming to the OS also, there is a 34% reduction in risk of death. And when we look at the time points at 24 months, 44.9% versus 26.6% alive. This is something which has not been found in this space post multiple lines of anti-HER2 therapy. So yes, tucatinib seems to be a drug for the future. And look at the forest plot here. Looks like in the baseline brain metastatic population also, the hazards are quite favorable. So how do you sequence all these drugs? So once we have all these options, so let me ask Aditya now, how are you going to sequence once you have tucatinib and TDX with you?
To be honest, Dr. Prashant, I actually don't know.
This was a setting where patient had brain metastasis and patient had undergone local therapies for the brain metastasis. What are you going to do?
No,
are you going to use tucatinib here if you have it available, or TDX? The CNS disease is now controlled.
So to be honest, the honest answer is I actually don't know. But given the data that tucatinib has shown, especially that the disease currently predominantly recurred in the CNS and the systemic disease was quite low, might be tempted to use tucatinib before TDX.
Dr. Anjana, anything different you're going to do? Are you going to prefer TDX or tucatinib for somebody who has treated brain metastasis? Or are you going to reserve tucatinib for later?
Well, actually, both trials included patients who had included actually a similar population of patients who had treated brain mets. So now between one or two, I'm not really sure. But if you look at toxicity, say maybe somebody has a bad lung, then maybe TDXT may not be an option, that sort of thing. But to be honest with you, I really don't know how I would make that choice.
So absolutely, this is something which has not been tested, and we don't have studies to come to a conclusion of which drug we are going to use. But when we look at the Destiny Breast 01 with TDX, the patients with brain metastasis, they also had a decent PFS at 18.1 months. And this is also a reasonable option for patients who have brain metastasis, especially the ones who have got treated with something like an SRS and are doing well and have a limited disease burden outside the CNS. So the problem with TDX, Dr. Anjana has pointed out, is the lung issues. For somebody who has a pre-existing lung disorder, probably tucatinib would be the way to go in future. But still, we don't have these drugs available. So the necessary experience is going to come with time, and there's going to be a learning curve to utilizing these drugs. And this is something regarding the ILD associated with the TDX. But yes, this drug is now approved and is there as an option, and quite an expensive proposition to use. So overall, we have newer drugs in both settings now, the early breast cancer, the LAVC also, and also in the metastatic setting. So only time is going to tell how we in India are going to put these in perspective and utilize it in various different settings. And we still are going to learn with time how tucatinib and TDX are going to change the treatment paradigm in India, and especially when most of our patients are still not able to afford these expensive drugs like pertuzumab and TDM1. So I don't know how much has changed in the HER2 MBC space or even the EBC space for India. Probably there's time to go, and probably some biosimilars and generics would be required in these zones, for these drugs as well. Thank you, the panelists, for a very nice and interesting discussion. Thank you, everyone.
Thank you.
Thank you, moderators and panelists, for such an eminent and panel. With this, we come to end of the first day of our the virtual conference, and we wish that all you would be present tomorrow for the second day of the conference, which will be starred by various national stars in the field of oncology. Thank you for participating in the conference. Good night.